بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. نبتدأ الجلسات العلمية. الجلسة الأولى راح يكون لها ساعة ونص لأن الوقت كلش مختصر. الانترفنشنال بالمونولوجي، التشيرمان الأستاذ كاميران قرداغي والأستاذ مصطفى مازن. الجو وياكم يا شباب.
هو مسجل. السلام عليكم. First, I will congratulate Iraqi Respiratory Medicine and Thoracic Surgery for this 6th International Congress. And I will thank for invitations. We are here to be a part of this conference. Thank you very much. And we have a very interesting session, pulmonary intervention. The first speaker, let me to, the name is a little bit difficult, Dr. Batabi Rahman. He is a pulmonologist and interventionist pulmonologist. He has been active in many organizations, internationally and locally. He has been active in organization conferences. And today he has a talk or presentation. Dr. Ali, we have a record for his presentation, please. And the only speaker, we can discuss the presentation after the record because it should be directly, but now we have a record of this presentation, not directly. And the title, Management of Hemoptysis in Bronchoscopy Suite.
Good morning. First up, I'd like to thank Dr. Ali Bhai for giving me this opportunity. I wish I was there, but due to logistic reasons, I had to do the next best thing, which is address online. I'm going to address very specifically about bleeding or handling bleed in a bronchoscopy suite. And this is going to be about 10 minutes. And I'll give you the principles of handling a bleed in a bronchoscopy using one case scenario. This patient is a otherwise alright middle-aged female who's presenting complaints with just occasional hemoptysis, had a mastral, had a CT, and CT showed some right middle of bronchiectasis here and some right sixth segment, a suspicious looking aspergilloma-like situation. And so the patient was taken up for a bronchoscopy, no other problems. And you could see a bronchoscopy showing this kind of a vague sessile polypoid lesion. So we just did a biopsy. We had to take a deep biopsy because it was a sessile polyp, and we had to get to the bottom of it. And when we did that, we immediately found out that there was something wrong after that because everything was dead. There was a huge spurter. This is an unedited video, but you could see that the blood just fills up. It fills up in no time. What do you do? Now, this patient was just sedated, and we don't have an anesthesiologist. We're doing it as a daycare, a regular procedure. And he had a significant ooze. We tried giving cold saline, which is the first thing to do. But then cold saline, you'll have to use 500 ml at least to ensure that there is a stoppage of bleeding. But that can't happen in a conscious sedation. So you just try some cold saline, try tranexamic acid. Nothing seemed to work. It was red all over. We knew things were wrong. We gave a call for anesthesiologist, and the first thing we did was to put in a Fogarty catheter. Now imagine, remember, within a minute, a Fogarty catheter goes in and it goes into the right side and you inflate it, and that is the most important thing. So the first principle is to localize the bleed, and of course there is a positioning aspect. If the patient did not have it after bronchoscopy and had it before bronchoscopy and he knew the site of the bleed either by x-ray or some gurgling sensation, you put that side down so that you don't contaminate. Remember, the problem due to hemoptysis is not because of loss of blood, it's because of loss of airway. So here, in order to ensure that the airway is not lost, the first thing is putting in a Fogarty catheter so that you isolate that area, you apply a tamponade so that the normal lung, in which case, this case it's the left side, is normal and other segments are all ventilated. So you ensure that you localize the bleed and also you will ensure that the airways or the normal airways are not contaminated by a lot of bleed. But this can't go on because the patient is the bronchoscopy, is a flexible bronchoscopy, and the channel is full of Fogarty now. You can't do anything else. You can't do anything to stop the bleed. So now we have stabilized. What next? See, in our bronchoscopy suite, we have a suite 2 and suite 1. Suite 2 is where you have a flexible bronchoscope without anesthesia, the conscious sedation stuff, and suite 1 is where we do all the major procedures. So now, here we had to shift the patient. Now you can see that the patient is in a bronchoscope. We applied, gave a little more sedation, and we have a team working here, some of which Dr. Ali can recognize possibly. You can see that there is a bronchoscope. The patient has to be moved along with the bed, and the Fogarty is in with the syringe, which is locked with the fluid that is filled with the balloon, and so balloon is inflated. So now, from here, this is the principle. So once you isolated the lung, the next stage is to stabilize it, which can be done either in a bronchoscopy suite if you have all the mechanisms. Otherwise, this could be the same thing where you can shift down to a IR lab where interventional radiology will do their things, or in worst case scenario, shift them to the theater. Now, each individual will have their own role. You could see that some of them are using the shifting, some of them are addressing, anesthesia requirements, some of them are addressing, connecting to a rigid bronchoscopy and setting up for further thing. And so there are a lot of nuts and bolts that needs to be taken care of. And there is an anesthesia technician who's come, and anesthetists have also showed up in the meanwhile. And so all these took about 15 minutes. Thankfully, the anesthetist showed up. And so now this is the process wherein you'll have to move from conscious sedation to a general anesthesia, and B, have a more conduit. Now the conduit could be rigid bronchoscopy or a wide bore endotracheal tube. In our case, it will be a rigid bronchoscopy because it's a very versatile structure. And now let's look at what has happened. Now you can see, you can take stock of the situation by having here with the anesthesia, and you can see that they still bleed upon reducing the Fogarty. Now, so we now have to use a conduit because this is not going to stop with just some more cold saline or adrenaline. So here we have to use a rigid bronchoscopy here, and you can see that this is just an airway. Patient is being ventilated. It's not an endotracheal tube. It's just an airway, and they're just passing oxygen here. And this is the bronchoscope, and the instrument channel of the bronchoscope is full of Fogarty. The Fogarty is occupying that. So we have to release that using a flexible bronchoscope. Using a rigid bronchoscope. Once the rigid goes in, you could ventilate. You could put the Fogarty on the side so that you can still attempt to tamponade. Whereas you can use, instead of the telescope of the rigid bronchoscope, you could use the flexible bronchoscope as a telescope so that that instrument channel can accept a laser or electrocautery or organ plasma coagulation to ensure that you can stop that bleed. So all these discussions are happening as the anesthetist also looks up and ensures that there is a smooth passage between a conscious sedation. Now the Fogarty is deflated and taken out, the flexible scope is out, and the rigid goes in. All these have to be done very fast because the patient has an active spurter. Thankfully, because of the tamponade, for some time it will give some time for us so that you look at the epiglottis, you push it up, and all the principles of rigid bronchoscopy is there. Once the tube is in, everyone is relaxed. Now there is a ventilation that is going to happen, and the rigid scope can actually, if there is a significant bleed and you can't control, we can always put the rigid scope into the left side and isolate the right side. And the Fogarty can be, passed through the laser component. There is another area that is free, and you remove the telescope and use a flexible bronchoscope. But we are not putting the Fogarty through the flexible scope. Here, the Fogarty will be threaded on this side. So now we move from a rigid bronchoscope to the flexible bronchoscope again, because rigid is inside as a conduit. We're doing nothing much with the rigid, and now you can see the bleed slowly accumulating and it started increasing, and the Fogarty comes in. Now the Fogarty you will see in the next few things is that it's not through the flexible bronchoscope, it's on this side, so that it goes in and then you inflate it so that you get time. So here is what the Fogarty goes in. So you can see how versatile this instrument is, rigid bronchoscope. You can do a lot of things. You can isolate, at the same time use it also as a conduit to put in different instruments to take care of the bleed. So you can see that there is a significant bleed still happening, and you can see that it's actually pouring continues despite all this, and so we had to resort to a thermal procedure. And you can see that this is a picture-in-picture. The anesthetist is quite relaxed, sitting on a chair, ventilating it, whereas we are fighting this kind of situation where there is a pour of an arterial spurter. Now, arterial spurter will not get better with either adrenalines or tranexamic acid and cold saline. You have to use a thermal technique. Here, we are using APC. APC, or organ plasma coagulation, is a very useful technique. It is a surface coagulator. Wide area can be treated at an instant, and you can see that the bleeding stopped right there. This patient, instead of going for a surgery or an interventional radiology, just moved to the next room, and following the principles of stopping a bleed, we could actually take care of the bleed, and so that the patient could be extubated the same day, and we could actually get the patient discharged. And you have some of the literature, especially this coming from India, where based on 979 flexible bronchoscopies, there were 8 deaths, of which 4 were due to bleeding. And so, if you're not prepared well, even if if it's a rare phenomenon, you could actually prevent bleeding in all those cases by sticking on to all the principles. So you could, this particular patient, the biopsy report came as endobronchial polyposis, and this was secondary to bronchiectasis, and you could see this was the biopsy. And I want you to concentrate on a huge arterial blood vessel, which is clearly seen by its thick muscular wall. So I think we've understood the components of what you have to do when there is a bronchoscope happening during, there is a bleeding happening during a bronchoscope. Either you're doing it for a bleed, or if the bleed happens after a flexible bronchoscopy, the principles remain the same. Localize the bleed, position comes earlier, but then localize the bleed, take care of the ventilation, and subsequently stop the bleed. So bleeding during FOB is rare but can be catastrophic. You need to have basic accessories at hand. Cold saline, adrenaline, Tremexa should be ready. But balloon tamponade can buy us precious time, and that's the most important thing of this talk. Every bronchoscope suite should have a Fogarty catheter. Call for help, use an anesthesiologist, work as a team, know everyone's role, and we have dry runs. Even if the patient doesn't have a bleed, we can simulate when we give the training to the trainees. We also actually give a situation when the patient is doing a regular, or when the trainee is doing a bronchoscopy. We'll suddenly ask them, say, what happens if it bleeds, and so we'll simulate it. It can be used to audit your team's role and how well they are functioning. And once you have that, work as a team and balloon tamponade, it can actually further escalate. Either finish off it in our bronchoscopy suite using a rigid bronchoscopy, or take the patient, shift the patient to IR or surgical care. So with this, I thank my team, some of whom I think Ali Bhai can actually identify, and I'll be happy to take any questions. Thank you so much.
Thank you very much, Dr. Rahman. Please be with us few minutes because we have questions from audience. Please. Any question? Yes, we have Dr. Rashid, please.
Good morning. Hear me. Why did you have the bronch as a first intervention? Why not intervention radiology? Is it resources a problem, or for hemoptysis? Is that the usual thing, or?
Is this a question asked to me?
Yes,
Hello,
please.
good morning.
Hi.
Yes. Yeah, so we divide it into the initial evaluation of hemoptysis when the patient has to be stabilized, and the stabilization can be done using either endotracheal tube, and we'll try to reduce the bleeding if it is from the visible source. In the case that was seen, it was done, the biopsy was done, and after that the patient had a bleed, so we could do that within the bronchoscope suite itself. But if it is due to something distal, we'll usually involve the IR also, which is in a different floor. So we have all the interventional radiologists and surgical backup also. But there are situations where even we can handle the bleed. So we're just trying to do the initial evaluation. The initial evaluation of a massive bleed is to secure an airway. And for securing an airway, you can do it either using a endotracheal tube, or in this situation where we've closed the bleed following a biopsy, we could use a rigid bronchoscopy. That's what we are saying.
No problem. Thanks.
Thank you very much. You have a question from Dr. Ali. Please, Dr. Ali.
Yes.
Hi, sir. Good morning. I'm Dr. Ali Bey.
Good morning, Dr. Ali.
Thank you for joining us, and I do appreciate a lot of effort and burden I caused for you. Really,
no problems.
Thank you. Thank you. Really, my questions is during such a critical conditions, we always try to save the airway, as you say, by oxygenation, by preventing rebleeding to other segments. But when you insert the thermal tool, now we have to reduce the FiO2 to less than 40%. Is this will be a problem with you?
Yes. So yeah, very good question, Dr. Ali. The thing is, here it was after a small bleed. I mean, after a small biopsy, but the bleed went significantly high. So we followed the few things. First is prevent the blood from spilling to other places by using a Pogati. And then after that, we clear the other areas. It was an edited video, but we cleared other areas, ensured that oxygenation came back. And those were following adequate airway control using a rigid bronchoscopy. And subsequently, he didn't require a very high oxygenation because the patient upfront was walking, talking patient. So there was not a problem with the pulmonary reserve. So after he reached that stage, only the last thing was to stop the bleed. So in order to manage a hemoptysis in bronchoscopy suite or in any ICU, first thing is securing the airway, ensuring that the blood doesn't go to other places. And finally, after the hemodynamic compromises are all taken care of, the last part is to stop bleeding using the thermal technique. So here, at that point, we had an option of shifting them to interventional radiology, or even if it is not possible, the surgery and all that. So we were just trying to discuss the options available out there. And if it is in a visible lesion, if there is a tumor bleed or a doliphous bleed or a bleed caused by a biopsy, we usually can handle using a thermal technique. And before reaching there, we'll have to ensure that all the other areas are taken care of so that oxygen requirement comes down. And after that, you can do safely the thermal technique. Thanks for the question, though.
Okay. Thank you, sir.
The last question, please, because of the time.
Good morning, sir. I'm Dr. Asim. Thank you so much for sharing. I was wondering, why didn't you use a narrowband image to check for the vascularity of the polyp before doing a biopsy?
Okay, so we don't routinely use the narrowband imaging, and this biopsy was not because it was a vascular polyp. It was because of the depth of the biopsy that we actually took it from the base, and so there was some bleed. It could have been secondary to a doliphus, but this was not a doliphus, which the biopsy showed. It was just an inflammatory pseudopolyp. It was just that a deep biopsy in the base was done. So, I mean, I'm not too sure if narrowband imaging would have produced anything, because it was not a submucosal vessel that bled. It was a bleeding happening because of the blood vessels that were behind, and we could still reach there because of hitting the base and strongly and picking the tissue up. So I'm not too sure if narrowband imaging would have made any difference to the bleed, I would think. Thanks for the question, a good question though.
Thank you very much, Dr. Rahman. So, thanks for your attendance and your experience sharing with us. Thank you very much. Bye-bye.
Completely my pleasure. Thanks to Dr. Ali. Yeah.
Thank you very much.
Thank you, Dr. Kamaran. Our next speaker will be Dr. Hadi Muhammad Abdullah. He is a board certified in internal medicine and respiratory medicine from Kurdistan, Slimani.
Good morning, everybody. Thank you,
Good morning.
Dear Chairman.
Okay.
Really, my talk is about the medical thoracoscopy. This is the left side. This is my hospital, Farouk Medical City in Slimani. The right one is the largest pleural procedure center in Turkey, Eskişehir city, for training. I think one of the best places in the region. What about the medical thoracoscopy? For us as pulmonologists, the medical thoracoscopy is one of the best tools really to see the pleural cavity. You can make a window. This is a window. This is a trocar you use. Through this trocar, you make a window to the pleural cavity. You can see all the pleural cavity. You can take the biopsy from the parietal pleura, sometimes the visceral pleura. You can take the biopsy from the lung under direct visualization, and you can aspirate all the fluid, and you can set a chest tube and the direct visualization and secure the condition. This is a good option for us. Also, for therapeutic reasons, sometimes you can use for opening loculation in empyema and pleurodesis. For the first time in the history, in 1910, Hans Christian Jacob is a Swedish internist. He used a cystoscope instead of thoracoscope to see the pleural cavity. He did the first medical thoracoscopy in the history to the pleural effusion, especially exudative TB pleuritis. Also, in 1921, he published the first case series of medical thoracoscopy results for the malignant and non-malignant pleural effusion. He's the first one, really. What about the indication of the medical thoracoscopy? We have many indications for the diagnostic and therapeutic one. For the diagnostic, the main indication is pleural effusion of unknown cause, recurrent pleural effusion without any identifiable cause. Sometimes for the staging, diagnosing and staging lung cancer, some patient present just with pleural effusion. It is not necessary to take the biopsy from the lung, from the mass. You can take the biopsy from the pleura. It is both diagnostic and staging. It tells you this the diagnosis and also staging for the lung cancer. Sometimes for the suspected mesothelioma, if there is a good adequate pleural space, you can take the biopsy also. For breast cancer, for hormone receptor determination, also you can take the biopsy from the pleura by the medical pleuroscope. For the TB, also for the to take the fluid and culture from the pleura, it is one of the best diagnostic modality really you can use. Diffuse lung disease, sometimes you can take the biopsy from the lung, not just parietal pleura, from the visceral pleura, you can take the biopsy. For local chest masses also you can take. For therapeutic, the main therapeutic indication is thallic poderage for pneumothorax and for recurrent pleural effusion. Malignant and non-malignant recurrent pleural effusion you can use. Sometimes in empyema, fibrinopurulent stage, not advanced empyema, you can open the loculations to re-expand the lung by medical thoracoscopy. This is an 81-year-old female patient with many comorbidities, rheumatoid arthritis, diabetes mellitus, hypertension, chronic kidney disease, three-vessel disease on dual antiplatelet, present with cough and the large loculated right side pleural effusion with a medical thoracoscopy for diagnosis and therapeutic. The video is not working, I think. No, any idea, my brother, not working the video. This is a fibrinopurulent phase of empyema. You can clean, you can cut the adhesions and to expand the lung. And also you can take the biopsy as well for the diagnosis. Just picture. This is the chest X-ray after the procedure. The lung re-expanded, and you can insert the chest tube immediately to drain more and to drain the air also. The second case, this is a large loculated left side pleural effusion in 66-year-old female. This is diagnostic and staging for this patient, really, suspected malignancy. We took we did ultrasound to know the side of the effusion, and we take the biopsy. Also, this video was, unfortunately, it's Zoom, I don't know. On mobile is working. يشتغل on mobile. I don't know.
لأن الفيديو موجود بالموبايل. لأن الفيديو موجود بالموبايل ما راح نشوفه هنا المفروض الفيديو هم يسويه.
Sorry for that. In this patient, we took the biopsy from the lung itself because of the nodular infiltration and few nodules on the parietal pleura also. The diagnosis, this is the chest X-ray after the procedure, fully re-expanded, and the diagnosis was stage 4 adenocarcinoma of the lung. What about the contraindication for pleuroscopy? Absolute contraindication in the absence of adequate pleural space. If you don't have adequate pleural space, you cannot insert because you may induce injury to the lung and any underlying organs. Pleural thickening, especially mesothelioma, when the parietal and visceral pleura fuse together, you cannot do that. Also, patient with previous pleurodesis as well, you cannot do pleuroscopy. Relative contraindication, intolerable patient, hemodynamically unstable patient, patient with severe refractory cough, you cannot do. Patient with a significant hypoxia, uncorrectable, you cannot do. And patient with short survival, better not to do medical thoracoscopy. If you don't have adequate pleural space, you may be able to solve this problem with pneumothorax induction. Really, for all my patients, I'm doing pneumothorax induction to get adequate pleural space. You can insert 100 to 200 ml, even 500 ml of air to the pleural space. You get a wide pleural space, and you can do the procedure. This, I think, is a good option. For coagulopathy, you should correct the coagulopathy before the procedure, especially the INR, better to be less than 1.2, and platelet more than 50,000 to 60,000 is better. For about the aspirin and clopidogrel, there is no any published study really to be contraindicated for pleuroscopy. You can do pleuroscopy when the patient on antiplatelet therapy, especially you can give platelet transfusion before the procedure. For any lesion you suspect that this is maybe vascular, maybe hydatidus, don't touch because you may not be able to control the bleeding. And any patient with advanced interstitial lung disease, not to take biopsy is better because you may induce bronchopleural fistula. Potential complication, really it is a safe procedure. Medical thoracoscopy, it's a safe procedure, but really you may face some complication, especially when you induce pneumothorax, the patient may get air embolism, which may be fatal really. But it's very, very rare, and pain, hypoxia, during the procedure, it's common, but it's not a problem. Re-expansion pulmonary edema, one of the fatal complications, but very, very rare because you have a flexible trach inside the chest. When you aspirate the fluid, the air enters the pleural space. You get adequate, good equilibrium between the intrapleural pressure and the extrapleural pressure. That is why it's very, very rare. Mortality rate, it is extremely rare, less than 1%. So it is a safe procedure. How to prevent complication? If the patient has severe cough, please don't postpone the procedure, is better. You should control the cough, then we have to do the procedure. For any patient with the cardiac condition, cardiac monitoring is necessary. For hypoxic patient, oxygenation. And insert a chest tube after the procedure to drain more fluid and more air inside the pleural cavity. So you can, usually you may get, sometimes you may get subcutaneous emphysema. You can start lung expansion protocol for the patient, chest physiotherapy.
Dr. Hadi, please, 1 minute.
Okay, the diagnostic yield for malignant pleural effusion is more than 95% for medical thoracoscopy. For TB pleuritis, is more than 99%. There is some difference between the VATS and pleuroscopy. In VATS, usually need GAs, and in operating room you can do. But the medical thoracoscopy and the bronchoscopy suit with the local anesthesia and moderate sedation you can do, really. About the diagnostic yield between the VATS and pleuroscopy, this is a new study, 2024. It is about the same. The diagnostic yield between the VATS and the medical thoracoscopy, this is the same. According to this study in 2019, the diagnostic yield for pleuroscopy 93.6, for VATS 96, not significant difference between them. This is my scope, really, or Olympus, with the internal diameter 3 millimeter. The light, the newest one is a good 27 cm is long, 22 cm is rigid, 5, the final, the end of 5 cm is flexible, this semi-flexible. This is my scope and my suit. You can, this is procedure step by step. The patient, the diseased side should be faced up, and you should put some pillow on, below the scapula to widen the scapular area. You should do ultrasound, please. Don't do the medical thoracoscopy without ultrasound. You have to know the location, the most dependent area. Then we have to enter. This is a marker to the side of the entry, point of the entry. This is all the equipment we need. This is a flexible trocar, the wide one by Olympus. This is after sterilization, after everything. We have to inject lidocaine 2% to the point of entry. Then, with the large syringe, we induce pneumothorax. 50 cc, 200 ml you can induce with the syringe to adequate pleural space. Then a small incision, 1 cm, and flexible trocar insertion. You should control the trocar with the palm of the hand, not to push rapidly. Then you can make the window, you can enter the pleural space, and you can take the fluid, also the biopsy. After the procedure, you should insert the chest tube through the trocar. After you insert the chest tube, you should reinsert the trocar beside the chest tube to assess the location, to see the location of the chest tube with the medical thoracoscopy. This is the chest tube inside the pleural cavity now. You see the chest tube by the scope. This chest tube should be connected with the water cell, and this is all the sample you can take with the medical thoracoscopy. Thank you very much.
Thank you very much, Dr. Hadi. So the third speaker is Dr. Mustafa Ni'ma, Management of Central Airway Obstruction and Bronchopleural Fistula. Dr. Mustafa is a well-known pioneer inside this branch. He is a pulmonologist, interventionist, and he has more than 20 articles in this field. Please, Dr. Mustafa.
شكرا جزيلا للأساتذة الأفاضل. بسم الله الرحمن الرحيم. Interventional pulmonology is an advancing field now, and in cooperation with the cardiothoracic surgeon, we have doing good work actually. So MDT, multidisciplinary team, is important in approaching of complicated respiratory patients. To start with, a new field I work in, which is treatment of a bronchopleural fistula. It is actually a nasty disease that the patient may need a chest tube for a long time, and may end it with another surgery, so that some palliative care could be done on the treatment of bronchopleural fistula with the injection of adhesive materials. Here, an 18 years old female with pleuropulmonary TB, and she was operated for decortication but complicated by bronchopleural fistula. I did the first session of closure using N-butyl glutarate material through a catheter by flexible bronchoscope, but that's what didn't cure the hydropneumothorax. Why it is not cured? Because there is possibility of multiple bronchopleural fistula as a case of TB. And a second session, I did another fistula closure, and she got a good improvement after a while. Here, the glue material that present at the fistula site, and this is the first session, and the X-ray didn't complete the resolution of hydropneumothorax. This is the first session. After the first session, this is the X-ray. But after the second session, there was gradual improvement and collapse of the affected lobe. We want to collapse the affected lobe in order to close the fistula and to get rid of the chest tube that is present in this patient for 8 months. 8 months chest tube or more than this for this lady, for this female. This is the bronchoscopic follow-up that the glue material are present in the place. It is not detached. And the last X-ray that the patient gets good comfort without chest tube. So, alhamdulillah, it was a successful procedure. This is my first bronchopleural fistula procedure. The second case, a 65 years old male with a bronchobiliary fistula, actually, because he had diastasis rupture of the liver, and because he was a smoker, congestive heart failure, he was not candidate for immediate operation, and the gastroenterologist referred for some palliative care and preparing the patient for a future plan for operation. And therefore, I discussed with him the probability of beneficial of bronchopleural fistula. This is the sputum of the patient. It was yellow on the right side. It is a bilioptesis. He is expectorating a bile almost always. And a bile is very irritant to the respiratory system, to the lung. And therefore, continuous infection like aspiration pneumonia, he developed without, and the oxygen saturation actually was in 80s for this patient. It's in distress condition. This is the closure of the fistula with the glue material, and you can see this by a bronchoscopy. It is well placed for this patient. Before the operation, this is the CT scan of the patient on the right side when there is multiple tree in bud, actually because of the continuous, sometimes bronchiectasis started to develop with this patient on the right side. After treatment with fistula closure, he gets some improvement, and the oxygenation improved. He was in a wheelchair, but he came again on walking by himself with good improvement of the CT scan. This is a palliative care. This is not a definitive measure because he had a bronchobiliary fistula and needs surgery. This is a palliation before surgery. The third case was a female, an elderly actually female, with also bronchopulmonary fistula and continuous leak without any improvement even after chest tube placement. So this is the CT scan with the hydropneumothorax. And this may be the fistula site in the lung, in the collapsed lung. And I did a pleuroscopy first for this patient because we have no idea about what the pleural disease, whether it is TB or other empyema or other conditions. And during the pleuroscopy, I saw the fistula actually in the lung. So I tried the new method, which is injection of a blood. autologous blood from the patient نسحب الدم ونخليه شوية يصير بكلوت نرجع نزرقه بالفستولة during the fluoroscopy. This is the first time also I did it, and alhamdulillah it was successful for this patient. And she came another time with improving after chest tube improving and the lung re-expanded. But later on, after 1 month, she also came with a total collapse of the left lung. Total collapse of the left lung. So I was surprised whether the fistula was only a small part, and I closed a small. Why? It is a total collapse of the lung. I did a bronchoscopy for this patient, and it was actually, it is a mucus plug only in the area, because she is ill and afraid to cough, and the mucus collected, and after bronchial toilet the lung re-expanded. بصراحة هذا كان fortunate. ليش؟ لأنه هذا التوتال كولابس ساعد أكثر على أنه فيستول كلوجر اللي كانت من فيستول لما صارت لونج كولابس باي ميوكس بلاك، بعد الفيستول انسدت ورجعت اللنج مرتفعة صار بها ري اكسبانشن. هاي بالنسبة للبرونكو بلورال فيستول. ناخذ شوية على central airway obstruction. Central obstruction, as you know, refer to obstruction of the trachea and major bronchi. It is associated with poor prognosis, and it complicates 20 to 30% of cancer patient. And non-small cell cancer is the most common one, classified either by the cause malignant, non-malignant, or intraluminal, extraluminal, or by the nature of obstruction fixed, or it is a variable or dynamic like tracheobronchomalacia. Malignant causes primary or secondary, and his direct or metastasis. Also non-malignant cell, many conditions like TB, like tracheopathia osteoplastica. Many causes are like this one with tracheomalacia, as you see here. There is a fish mouth like, you can see during a bronchoscopy when the patient breathes, the trachea is collapsed, especially if it is associated tracheobronchial malacia, not only the trachea. So it is a congenital type, and the patient, usually younger age group, presented with some sort of barking cough, non-reversible cough, even with the treatment. And you need to do bronchoscopy to see the tracheobronchomalacia. And treatment actually with CPAP for this patient, or tracheal stent, tracheobronchial stent. The causes of clues to diagnose. شو كنت نعتقد انه هذا المريض عنده central airway obstruction. لما يصير the constant dyspnea, you're not responding to bronchodilator. الشيء الثاني تسمع unilateral wheeze، والشيء الثالث radiological finding or symptoms that persist despite treatment. تعطى treatment بس تبقى هذا الباتش موجودة، تبقى هذا موجودة، فنعتقد انه اكو. Tracheal diameter is important. When tracheal diameter is less than 8, the patient will develop exertional dyspnea. When the tracheal diameter is less than 5, he will develop stridor. So when patient came to you with stridor, this means a significant and a very grave prognosis, and you need to interfere immediately. So central airway obstruction need a high index of suspicion. We need to suspect central airway obstruction in every patient present with these clues, with these risk factors. Cryorecanalization, one of the first modality actually I work in, and you need to do it to distract the tumor or the lesion, so I can benign or malignant. It has an immediate effect, and it has a delayed effect because of thrombosis of the vessels and crystallization of the vessels that you will do, and the tumor may dissolve after 1 or 2 weeks after your procedure. After recanalization, you can get a normal caliber by 60 to 90%. Performance will be improved, and the vital capacity and oxygenation will improve in 70% of patients. Mortality and risk, it is of low mortality, and total complication less than 10%. And fortunately, the risk of perforation when you do recanalization and debulking of the tumor, no perforation, because the cryo will not, the cartilage is cryo resistant or crystal resistant. It will not freeze الكارتليج. فايش قد ما تسوي انت بروسيجر ما راح يصير عندك perforation. احسن من الليزر يعني من الارجون. This is the first case of 64 years old stridor and subglutic mass. لما نشوف الاكس راي مالتنا نباوع على هاي المنطقه راح نشوف there is narrowing of the trachea and the tumor in the upper part, a widening of the upper mediastinum actually. At the same time, you can see there is possible metastasis in the lungs. يمكن الفيديوهات معروفة بها مشكلة. أي أكو فيديوهات مع الأسف ما طالعة. This is a second patient with the tracheal invasion and invagination of a trachea by a thyroid cancer that passes through the trachea. And cryo procedure done for this patient. Cryo procedure done for this patient. الصورة مال الفيديو ما طالعة بس هاي after the cryo there is كان اكو tumor بالفيديو هنا after the recanalization it is now opened and recanalized. This is also 32 female with progressive dyspnea wheezing and lastly develops stridor. She is a younger age group, preventive stridor, and diagnosed as asthma and treated as asthma without CT scan. The CT scan showed total collapse of the left lung. And here is the tumor that present on the carina actually, and gradual cryo debulking done for her, and she after that became free of cryo. This is the tumor that extracted, and this is the following cryo. Just after 1 month, there is only a small remnant of the tumor here, so it is an opened airway, and the patient now without stridor. This is the X-ray before. This is the X-ray after the cryo. This is the third case of 55-year-old male with marked dyspnea, and I do a cryo and then chemoradiotherapy and another cryo sessions. You can do cryo or argon for coagulation or other procedure more than one time after follow-up because the tumor may be regrowth
Mustafa,
again.
we will give you 2 minutes extra.
Okay.
From now.
نتوقف؟ Okay, شكرا. This is the amount of the tumor that you can extract from the procedure. طبعا البروسيجر قد تطول ساعة أو ساعتين لأن تحتاج piecemeal removal of the tumor. Another case of a young female. You can see here at the level of the carina there is a tumor and there is a starting collapse of the lung. Also diagnosed as asthma and treated with large amount of steroid long term with cushingoid syndrome. This is the tumor on the trachea, on the carina, and this is the tumor on the bronchoscope. It is a large one actually occupying totally occupying the main bronchus. And طبعا الصورة ما موجودة. This is the case, also another case before and after recanalization. This is also a large tumor here for another patient with recanalization here. Argon photocoagulation, another procedure. وأنا مخلي الصورة كنت مال argon فيديو شلون إنه نسوي control of the bleeding بس هم طالع الفيديو للأسف. Diagnosis of central air obstruction by clinical and spirometric لما نشوف low volume loop خاصة لما نشوف البوكس لايك هذا معناها fixed upper airway obstruction. واكو عندنا variable intrathoracic variable extrathoracic obstruction. الفلو فوليوم كلش مهم نباوع عليه بالسبيروميتر حتى نتاكد انه there is an obstruction or not. The follow-up of radiology of this patient, like this total obstruction, and after this is the tumor, recanalization, stenting, and then growth of the tumor and recollapse of the lung. CT scan you can estimate. And PET scan you can differentiate between collapse or there is a tumor invasion. فهنا البيت سكان شوفنا انه tumor here والاذر هو الكولابس مو كلها tumor هذه. طبعا السيتي سكان مهم انه نشوف الفيرتشوال برونكوسكوبي. MRI اذا كان عندك فاسكولار رينج شو اللي مسببت لنا الابر ايروي اوبستراكشن. By bronchoscopy you can differentiate between intraluminal and extraluminal or combined. Okay. كل ما كان التيومر pedunculated يكون the chance of removal is easy and without complications. You can do also another laser therapy electrocautery. electrocautery متوفر عندنا الكرايو متوفر والستنت ايضا متوفر بس يعني مو انا اشتغل بيه وعندنا البالون dilatation همينه a procedure you can do it to dilate a trachea or a bronchi. You can do the procedure also with argon plasma coagulation and dilation by the balloon كرايوثيرابي تستخدمها للديليد، يعني مو بس immediately. يعني كل ما كان البيشنت acutely presented تستخدم اما ليزر او ارجون. اذا كان delayed والبيشنت cold case تستخدم الكرايوثيرابي لانه it is delayed effect. يعني ما تدخل واحد emergency وعنده suffocation ومستخدم له تيوب تستخدم له الكرايو، تستخدم له الارجون احسن. Stenting, this is the new era of development. These are difference between every type. شو وقت تستخدمها الeffect والcomplications. It is very good for to do impact of intervention, bronchoscopy, and the Borg score will improve in almost these patients that studied in certain area. Surgery also with the multidisciplinary team, whether the patient needs surgery or not. Inoperable patient تستخدم له طبعا palliative care. تستخدم له palliation وبعدين surgery تقدر. A new investigation injection of cisplatin intra-tumor injection of cisplatin. Other causes like this neonate هذا هم patient اجى الحقيقة هم كان عنده hemangioma عنده trachea. This is a tracheobronchopathy osteochondroplastica. طبعا it is a rare condition. هم يجي asthma like and nodules. This is the thyroid causing هنا على اليمين tracheal obstruction. tracheal narrowing post in the tracheal tube وشوف السبيروميتر شلون مختلف عندك. In conclusion, a lung cancer patient with inoperable diseases and symptomatic airway obstruction, you can do a therapeutic bronchoscopy to help the patient, to help improving the morbidity and mortality, and emphasizing the importance of MDT. لا تاخذ قرار لوحدك، دائما وياك السيرجن وياك الأونكولوجيست حتى ناخذ قرار سوية. شكرا جزيلا لاستماعكم.
شكرا أستاذ مصطفى. Our next speaker, Dr. Amir Zahir, is a well-known cooperative pathologist, College of Medicine. رحب بالدكتور أمير.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. And actually, thank you for getting this opportunity to highlight this important subject, which is a very important complementary tool that may improve the value and the results of EBUS. What is the ROSE? ROSE is a rapid on-site evaluation of a sample. Rapid on-site evaluation of a sample. Why? To ensure adequacy and proper triaging of this specimen. You know, the adequacy is very important part of sampling a biopsy or a cytology specimen. Without ROSE, without rapid on-site examination or evaluation, non-diagnostic rate is about 20, while with ROSE, you can see the difference. Without rapid on-site evaluation, non-diagnostic or false negative result may be 20%, but with ROSE, it reduced maybe 2 to 10%. A central goal of ROSE is to optimize the quantity of diagnostic material procedure during aspiration procedure, including triaging and anticipation of any ancillary measures. Not only adequacy, to say it's adequate or not, but we can divide the specimen according to our suspicion, whether it's inflammatory process to get the material or sent for searching for infection or molecular study, or it's a neoplastic process to send or prepare a material for ancillary studies such as immunohistochemistry or other tools. So, become a real need in interventional medicine. Why? It may be simple to repeat a sample if it's a fine needle aspiration done on daily clinic. You can say the patient, we need to repeat the aspiration on the next time, maybe tomorrow, but with interventional procedure, it's very difficult to repeat the interventional procedure because the material is not adequate. So when aspiration material is not adequate, let's imagine without ROSE may repeat the procedure as a whole. But with ROSE, we can only repeat the passing of the material or fine needle aspiration. So it's make difference. Defining criteria for sample adequacy, how we can say it's adequate, this is an important issue. It's maybe an objective issue, but sometimes it's a subjective issue. Adequate does not mean a diagnostic. The rule of rapid on-site evaluation is not diagnostic tool. It is a complementary tool to see the adequacy. So it's not diagnostic. So adequate sample, defining adequate sample, how we can say it's an adequate sample? It's a long tissue core. If there's, during aspiration, we can get long tissue core more than 2 centimeters, this is adequate. Or anthracotic pigment seen in macrophages that present, so we are sure in a lymph node if there's aspiration of peribronchial lymph node, so we are sure getting a fine needle aspiration from lymph node because we get anthracotic pigment. And defining definite malignant cells. Sometimes we can see definite malignant cells during the procedure, and this is diagnostic, and we can say the material is adequate. Of more than 40 lymphocytes, the lymph node may be negative. It's not. This does not mean that it's a false negative result. Presence of lymphocyte may be adequate, so we may aspirate from a normal lymphocyte. Applying these criteria, the increases procedure sensitivity from 65 to 97%, we can see. So the material is little, and what we need to evaluate what's needed from the pulmonologist and what needed from the pathologist to say the material adequate and stop at here. First, proper path. What's needed from the pulmonologist? First, proper path of the fine needle aspiration needle in the exact lymph node, according to the imaging criteria. Pushing the sample on the slide is very important. You know the material is very precious and very small material, and how to push the material on the slide to be spared, this is very important. So just like a gold, if we dilute this material by normal saline, for example, this will disrupt the material. So it's better to push with air on the slide. And it needs a patience from the pulmonologist to get the results. Actually, it's not an immediate procedure. It's a rapid evaluation. يمكن دكتور علي ما يقبل يقول عين على الشاشة وعين على الحلقة نشوف الريزلتس مالتها. It's not an immediate, it's a rapid procedure. So it needs some patience from pulmonologist to get the results. And what's needed from the pathologist or the technician, spreading of the specimen is very important to not disrupt the material. A staining procedure and staining material and staining quality is very important, and screening for the field, for the exact field to say it's adequate or not. We may do many slides, and we should select the possible slide, the important field to discuss. This is an example of spreading material on the slide. Maybe too much to put many blood drop on one slide. This may affect the picture of the slide. And a small droplet may be adequate, actually. And this is the way we spread the slide. It's either in this procedure as in this procedure, or we'll do with an angle or 45 angle. Both of them, if done well, they are adequate and they are right. And this is the difference between in the spreading of the slide between adequate procedure and inadequate procedure. It depends on the power, how to spread the slide. For example, on the left side, the pathologist may be so anxious to press the material too much and the smudge the cell, so the picture is not well. Just like looking from behind the ground glass. While in the middle, it's well, but it also disrupts the material. But the proper spreading of the material on the slide, we can get very good results and very good cellularity and very good appearance of the cell. A staining procedure, we use a rapid staining procedure, including the DefiQuick or Tolidine Blue. Definitely the staining procedure will affect the results. So we can see here, properly stained the slide, we can see the quality of the cell, while improperly stained the slide will affect the procedure and give false negative results, certainly. After saying it's adequate, it's important to triage the sample. Where should I send the sample? Whether it's neoplastic or non-neoplastic process to start searching for infection or searching for malignancy. If we decide that it's neoplastic, we can guide the specimen to either either it's hemopoietic or non-hemopoietic. For hemopoietic, we can save some sample to say it for flow cytometry. We can get results or diagnostic results for the hemopoietic malignancy. Or it's not hemopoietic, we can save some of the sample to do cell block preparation, and you know what's the value of cell block preparation. We can get different results by doing ancillary studies such as immunohistochemistry or molecular study on this sample getting from a fine needle aspiration. Or if it's non-neoplastic, we can say sample for molecular study to search for tuberculosis, for fungal infection, special stains to search for certain type of bacteria, and so on. So this is the second rule of ROSE is the sample triaging according to our suspicion from the first examination of the specimen. Touch imprint, this can be done also on biopsy material, not on fine needle aspiration. We can imprint the biopsy, the core taken from the procedure on the slide by obtaining some core placed on the slide and rolled according to this procedure. ناخذ الكور نفسه, imprint on the slide, gently we'll roll the core on the slide, and we can get some results, just like a cytology. We print the cell on the slide, and we can stain them, and we can get some results. Cell block preparation is very important. As we said, if we suspect a neoplastic process, we can save some material to do cell block preparation because we can do a certain ancillary study. If combined with routine smear, the sensitivity increased by 90%. Sensitivity of the procedure. EPAS sample taken from EPAS increases the sensitivity up to 90%. Some recommend it as routine work. Actually, it's better to be recommended if the neoplastic process is suspected. Other recommended to selected cases, particularly in suspicious cases, should not expel all material on the slide. When you take a fine needle aspiration during EPAS procedure or any fine needle aspiration, whether EPAS or EOS, better to save some material before the results of ROS comes, because when I suspect malignancy, we can save the material, the other material for cell block preparation. So not expel all material on the slide at first. Please spare some material for cell block preparation. Value with immunohistochemistry and molecular test is very important. And this is the technique of getting cell block preparation, fluid. Here in the cell block preparation, we need the material to be clumped. We assist in clotting of the material. To get a clump, blood clot or a clump, and we can deal with this material as just doing a biopsy. Fine needle aspiration يمكن الأمور أسهل لأنه be blood material and can assist the clot. مرات بالبرونكوسكوبيك biopsies يعني bronchial wash تكون الأمور صعبة because there's a mucus that compete with the blood to make a clot. فممكن هذا الميوكس affect clumping فتكون cell block preparation شوية أصعب بالبرونكوسكوبيك بالبرونكيال wash. بس بالfine needle aspiration whether during EPAS or any fine needle aspiration may be easier to make a cell block preparation, and we can do other ancillary study. This is one of our cases that its problem can be solved by the ROSE examination. This is very critical. The patient had a lung mass with imaging. There's a subcarinal lymph node. Dr. Ali يمكن arrow this subcarinal lymph node, and during the procedure we do ROSE, and we can find this malignant cell. So the management of this patient affected, they designed for surgery because there is no subcarinal lymph node on the first imaging, and they decide for surgery. But after re-imaging, there's a subcarinal lymph node, and the management of this patient markedly changed from the surgery to chemotherapy and other palliative management, because we do ROSE and we find malignant cell. And but actually, we should confirm by routine staining, H&D stain and papinicula stain. Thank you very much.
Thank you very much. The next speaker, Dr. Rebas Salah from Power Hospital, Erbil, and he has a high diploma in medicine and respiratory medicine. He has been very active in intrabronchial intervention the last years. So he has talk about EBUS, TBNA. It's really a question. It's enough or more needed for diagnosis mediastinal cryobiopsy with a new technique. Please, Dr. Rebas.
Good morning. I think it's still morning. We're going to talk for today about the mediastinal cryobiopsy. Sometimes we can take a tissue from the mediastinum, but still we cannot persuade the pathologist to give us a diagnosis. And what shall we do? And we have to have a better tissue and better sampling. So I have to go there. Okay. What's mediastinal cryobiopsy? Simply, it's a minimally invasive technique. It's a very safe procedure, and you can have a large piece of tissue so that you can have a more molecular profile. And the indication is various. Actually, I don't want to bother you with lots of indication, but what's important, any solid mass in the mediastinum, you can take at the biopsy. For example, for diagnosis for the first place, or for staging, restaging, or for the second time, if you are doing EWAS TBNA and still you are not diagnosing the case. And for any places to be mastered, you have to know your map, and this is a mediastinum. And before that, how you can take a biopsy from the mediastinum is very important, actually. And there is a couple of questions you have to ask yourself. For example, whether the lymph node or a mass from the center or from the peripheral, and how we can reach this mass is very important. Because we have a couple of ways that we can reach the mass. For example, by through the trachea or through the esophagus. First, we can have we can have a TBNA, a usual TBNA, by an EBUS, and we can pass through the lymph nodes, and then we can take a biopsy directly from the lymph node. And sometimes we can have a good tissue, but still we cannot convince the histopathologist to give us a correct diagnosis. That's why we have to go and to find another way to get more tissue. This is a usual TBNA through the tracheal route. Sometimes we have a tissue from the other side, for example. And even if the, here, sorry, yeah. What about if the lymph node is a small, even still you can target the small lymph nodes or amatses inside the trachea, and then you can get your rows. It's a rapid onset assessment. You can put it on the slide directly. I hope the histopathologist, Dr. Amir, convinced about this spread. I'm helping my histopathologist because he's beside me, and how we can just prepare the slide. But sometimes we have another way. For example, we have station 8 and 9 that we cannot reach there by a usual way of trachea, and then we have to do a complementary way, and we have to go down to the esophagus, and we have to find the way, and then we have to puncture our target. And then you have to pass through the oral one, not the usual endotracheal tube or an eye gel. And then you can take a biopsy directly from the esophagus to your target. Most probably, usually station 7, station 4R and 4R and L, and also 10. This is an esophageal way. Still, sometime we are doing our effort. We are reaching the target and we are having our tissue, but still we are not reaching the diagnosis. Now, what shall we do? And we have a way of taking more chunks of biopsy, what's called mediastinal cryobiopsy. Then how we can do it? By you have to have a cryo machine. This is an RB1, and then you can set your seconds, and then you will open the solution, and then you will combine, and you have to have a prop. This is 1.1 million prop. Then you have to sedate your patient, whether the deep sedation, through the oral, through the eye gel, through the intubation, or anything. It's okay. Okay. Then for now, we're going to talk about how to take a biopsy from the mediastinum by the cryobiopsy, step by step. The other steps, they're almost the same, but the most important, the first one, you have to put your plan, how you can go, how you can reach, whether it's a central or it's a peripheral. The second step is a puncture. This step is guide you how you can go directly to the target and how you can have your tissue from the capsule to capsule, and you will have your a good amount of tissue, and you have to have your way for the next step, which is how you can tunnel and how you can pass the cryoprobe to inside. From this way, if you can notice it, we can pass from the capsule to capsule, and if you just if you have an intention on the lymph node, we can have what's called fanning. Then we can take the lymph node from capsule to capsule and from the side to side, so that we can have a little bit of journey, and we have to have cells from the different parts inside the mass. Then this is a most important thing, is how we can a tunnel so that we can pass a cryoprobe. Two way of tunneling till now worldwide is either you're putting an electron knife, or you will have an 19 gauge needle. But this is a new way that we did it actually. This is the first time. I think for the future we will have a new Iraqi way of taking a mediastinal biopsy is writing. So far we did more than 20 cases. And what's the idea? This is here. The idea is we are using a usual 22 needle, but what's important here, we are after having a sample, we are pushing the sheath, not the needle this time. We are pushing the sheath over the needle so that we can make the needle just like a guide wire. And we have to break the mucosa. This is a very important thing. We have to break the mucosa so that we can get there. And here, if you can see directly from the lymph node, sometimes you will lose your vision because you're going to push the sheath over the lymph node. But you have to be careful because you know the major vessels underlining. But still, it's very safe in an experienced hand. Then after you will have your tunnel, then the second step is what? And you can go down with your cryoprobe and you can take your biopsy. This is your cryoprobe. It's very easily and smoothly passing over and going inside the lymph node or a mass. And then you can take a biopsy from the different levels of the lymph node, and you will have a chunks of biopsy. By that way, sometimes you can solve the problem, and most of the time you can convince your histopathologist to give you a diagnosis. And then the whole procedure, it will be very easily. You'll have your plan, you'll have your puncture, then you'll have your tunnel. Then after that, in any level that you want, you can take the biopsy. And most of the time, you know, the risk of bleeding and the complication is extremely low, and you will have most of the time we are taking 3 biopsies, and 3 to 4 biopsies, but most of the time 3. Then we will have our diagnosis. For the future, so far with this new way, we did 20 cases, no complication. And for the future, we have to compare with the two most common ways in the world nowadays. As a conclusion, still it's a minimally invasive technique. And it's very safe in an experienced hands, and you can, we are not doing, by the way, for the all cases. We are doing for the specific cases, mostly for the benign cases, lymphoma, TB, and other things. And still, this is for the central way, and if we can control the whole mediastinum, we have to reach the peripheral as well. For the first time, we're going to have a radial e-bus as a new one, as an SP 900. It's going to be launched in the new year, but still we have a long way to go. As Ustad Adnan said, for the future, we have to improve also. Thank you.
Thank you, Dr. Ribaz. Our next speaker, Ustad Ali Saleh Bayai, is the head of medical department of Hammurabi Medical College. Rahab Ustad Ali Saleh. His talk about his vital tools to do endobronchial ultrasound.
Well, thank you very much for everyone. Really, after this nice journey in interventional pulmonology, what can I say with sure? We are no more lag by the IP field. I think after all we listen, after all we see, after all these new things, I think we are no more lag behind the war in the IP. And we can say with some evidence, we are here. Thank you for all who work in this field. Now, thank you. Now I will talk by something little bit different. It is an clinical, technical part. This is the things that should not be concerned by the physician. This should be concerned by something else. But that's what I will try to do it. In any doing IP procedure, we have two concerns. By the way, I think I can't talk in بالعربي احنا كنا نعرف. Safety and efficacy. أنا من أريد أسوي البروسيجر لازم البروسيجر تكون safe وتكون effective. كل الحكي اللي شفناه من الكرايو بايوبسي من الروز من it's to improve the efficacy. ما أنا أريد أخلص البروسيجر ورا أقول له للمريض we are sorry the sample is not adequate, we are sorry the diagnostic is not the procedure is not diagnostic. So I want to improve the efficacy. هاي كل الأشياء اللي احنا نحاول نسويها من الصبح لحد الآن. So what's the things need to do or to have when you have the EBAS? First, you have to have the staff. Always I say, من أبدأ أشرح على الإيباس أقول لهم it is a 3-hand procedure. مو إيدين اثنين, 3-hand procedure. You have to have a well-trained staff with you. Second, you have to have the tower. You have to have the machine. وهذا أعتقد الموضوع اللي إحنا ما نتدخل به كلش لأن إحنا يا دوب إحنا we beg for the machine. لكن الشيء المهم اللي إحنا لازم نتدخل به is the needle. الأداة اللي أنت تستخدمها بإيدك هي النيدل اللي أنت لازم تعرف شلون تستخدمها وشنو الأشياء اللي أستخدمها بأي طريقة. The personnel as I told you it is a 3-hand procedure. لازم طبعا بالمناسبة هي أكثر من 3-hand procedure. لازم أنت تشتغل بإيديك الاثنين والأسيستنت وياك وأبو التخدير يعني حكاية دائما أنا أحكيها أقول لهم أينشتاين يقول الرياضيات أخرت الفيزياء. يقول أنا عندي معلومة أعرفها ومتأكد من عندها بس على مود أشتقها بشكل قانون رياضي آخذ لي 5-6 سنوات. أنا الحكاية اللي دائما أحكيها الأنستيزيا أخرت الآي بي لأن أنت البروسيجر كل سهلة ونطب تسويها وتطلع بكل بساطة بس احكي لي أبو التخدير شلون يقدر يطببك ويطلعك. وشفنا يمكن الأولى مال الدكتور باتافي يعني ترى لو ما أبو التخدير موجود كان الأمور اختلفت. من صار بليدنج وضاع الفيلد أبو الأنستيزيا. فalways this is a team to work with this procedure. The needle. Does the needle make a difference? Can increase the diagnostic yield? هذا اللي راح نحاول أفتهمه هسه. 3 أشياء لازم أعرفها عن النيدل. النيدل تيب النيدل ماتيريال، النيدل جيج. من تريد تشتغل لازم هذني الثلاث اشياء تعرفهم. هاي النيدل تيبس، عندنا اول وحده هي المنجيني نيدل الاي ان بي، هذه اللي هي موجوده مع شركه اولمبس الفيزي شوت. هذه مثل ما تشوفوها عباره عن شيء مفتوح بهالطريقه. it will take a tissue in this way. السي هي مال كوك اللي يصيحوا له الهيدن تراب اللي شلون صايره جانبيه، فانت من تدخل راح تاخذ يعني بالهيد وبالجانب. الفانسترا اللي هي مال شركه الخاصه راح نشوفها. This is a 3 heads. This is the needle. Olympus هي المنجيني مثل ما قلنا. فائدتها تعطيك easy access movements, large amount of tissue suitable for immune histochemistry and for molecular tissue, more ecogenic, but it is more traumatic. Boston. This is the needle for Boston. It's the 3 heads, so it can take a good punch. مو slip واحد, 3 heads. It can put a very good punch. Cook مثل ما قلت لكم يبي التراب البروكسيمال. And this is the difference between the heads. Material. هاي كلش مهمة. ليش؟ It affects the flexibility. أنا أريد أوصل إلى مكانات little bit صعبة، وأصعب وحدة دائما إحنا يعني بالتريننج كورس نخليها آخر وحدة هي دائما ال 4L، لأن ال 4L أنت لازم تجي يعني إذا if we suppose this is the carine هيجي ولازم أفتر على هاي الحركة أحتاج فليكشن تقريبا 90%، وهذا ما تقدر تسويها وأنت مدخل نيدل بنصها. فهذا اللي يحدد لك الفلكسبيليتي. فسوم انت داخل على مكان صعب لازم تختار اكثر نيدل فلكسبل. واثنين الديوريشن. if you are the investment، اذا انت صاحب المال لازم تجيب وحده ديورابل وتكفيك تشتغل بها فترات طويله. The most flexible one to reach the difficult اللي هي ال 4L with good side of ejection. نيوتونيان اللي هي الكومبينيشن مال تيتانيوم والنيكل. هذه هي المور فلكسبل وان which is the new Olympus، هي الفيديو شوت. الكوبالت it's the durable with multiple passes. هذه احسن وحده يعني من انت ابو الفلوس لانه هاي راح تطول عندك كل شيء هوايه. and the stainless this is the old needle but it is very hard. هاي مستحيل تفر السكوب وهي طابه بالسكوب. this is the way what I talk. هذا من السكوب واحده يدخل بزاويه 90. بس شوفوا كل ما تدخل نيدل انت تصير مور ستيف. يعني لوك هير يا دوب انت توصل 45. فانت تحتاج شيء الفلكسبل اللي يوديك لمجال ابعد. This is the way of EBOS flexion. And now the most important things and the last things is the gauge. هاي لازم تحدد الجيج اللي تفوت بيه. احنا الستاندر 21 22 and you will see in the workshop عندنا ال 22. لكنه these are طبعا ذني يمثلا شو اقول 90% من الشغل مالتنا. but these are not the only tool you have to work with. وانما you have the 19. it's what we call the histology needle. هذه لومن كبير تجيب تشو كبير تطلع تشو جيد للهيستوباثولوجيست لكنه تروماتيك. اكو علاقه شو يصيحوا له عكسيه بين السايز والتروما. كل ما اني ادخل بشيء اكبر اطلع تشو اكثر، لكن اطلع تروماتيك اكثر يكون بلانت اكثر. دكتور امير دائما من يصير بلاد يقول لي بعد لا تاخذ من هذا المكان لانه هذا المكان صار بلاد، والبلاد يلغي الموضوع بعد ما تشوف. فكل ما اني تروماتيك اكثر تشو اكثر لكن دايجنوستيك اقل لانه الصوره تضيع. So this is the histology needle. هاي انا غالبا استخدمها ورا I have the diagnosis. يعني مثل ما قال دكتور he told that انه هاي malignant هاي non small. هسه احنا تحولنا الى مرحله نريد tissue for immune histo اطبب ل 19. اوكي؟ بينما اللي خذتها بال20 او بال21 it's give more tissue but more traumatic. The efficacy on diagnosis is not so good but it is very good for molecular and immune histo. ال25 هذه صغيره كلش. هذه الطب ايش تعطيك cells. Very good for diagnosis but very poor for immune histo. So it is a matter. فالسكاجول اللي تبدي بيه او الخطه اللي نبدي بيها مرات انا ابدي بال 25 انا مود اي جت دايجنوسيس لان راح تجي دكتور امير راح تجي شو كلش حلو نازك ولطيف وما مضروب not traumatic so he can make the diagnosis ورا ما we make the diagnosis to the heart tissue for immune histo I will insert ل 19 okay we expect give a very fine tissue let's هذا الفيديو اذا نقدر بس ما مشتغل للاسف هو هذا يبين لنا ما راح يشتغل هذا يبين لنا الواي اوف الدخول مالت النيدل طبعا هاي اول وحده كان المفروض ال 19 راح تدخل عدل بينما راح لو تشوفون الثانيه يعني اللي المفروض هنا لما تشتغل تدخل بشكل كيرف لان هي ال 25 او في اللي هي السايتولوجي نيدل and thank you very much.
Thank you very much. So now the presenter, please come to the stage. So we'll discuss. And the last presentation, we will move into the COPD session. So the last COPD talk will be the next session. So, Dr. Mustafa, please the speaker come to the stage to have a discussion. What? Okay. Yes, please. So, okay. Any question? Yes, please. Dr. Adnan, Dr. Ron.
I think Dr. Hadi is
Dr.
not here.
Hadi.
Okay.
Chlorodesis, medical chlorodesis. Have you used, any one of you, tetracycline in place of tau?
Yes, yes, we can use if the talc is not available. أنا بالنسبة لي أستخدم دوكسيسايكلين لأن الدوز أقل من تتراسايكلين وإت سكسسفول الحقيقة. ومرات أستخدم إذا مثلا دفعت التالك وكان فيلد تالك في النكست سيشن أستخدم دوكسيسايكلين. وإت واز سكسسفول in most of the cases. بس لأنه التالك متوفر أستاذنا والدوز أقل ولس painful for the patient نستخدم التالك. إذا ماكو التالك نستخدم دوكسيسايكلين.
Well, I have experience. I did a study 25 years ago for those with recurrent malignant effusion. And it was actually painless. Few patients develop pain that could be relieved by just paracetamol. And again, it is, you know, the talc would produce a lot of fibrosis and things. And
احنا نريد الفايبروزس بالعكس.
not, I don't mean the fibrosis per se. I mean it leaves something after. But if regarding efficacy, it is very effective, and it is cheap and available. I mean, yes. All the points toward the tetracycline, and only 2 patients, they didn't respond because they are end stage malignant pleural effusion. Thank you.
طبعا عند البين أستاذ روتين use xylocaine mixed with the tetracycline normal saline تقريبا 20 cc xylocaine 2% نستخدم to decreasing the pain.
We didn't use any xylocaine for our group of patients.
زين.
Okay, thank you. Dr. Rawant, the second one. And you have the, after that, Dr. Rasha. And you have the other. Okay.
Thank you for all the speaker for the nice informative information. I have the question for Dr. Amir regarding the role of the rose in those patients have the CT guide or ultrasound guide biopsy, because we know for those peripheral lesions we suspect the malignancy. They will send for the CD guide biopsy. After the let's say 2 weeks, the result come back that it's not the malignant or it's not proper biopsy taken from the patients. It's not about we see in the EBUS and the invasive, but why it's not present in the CT guide biopsy for those patients? Have the CT guide biopsy directly to the rose for the patient?
Yes. We said about the imprint cytology for the biopsy material. We can apply rose for biopsy material by imprinting the core biopsy on the slide. It can be applied.
Yeah.
This can be applied for core biopsy by biopsy imprinting on the slide, and we stand by rapid procedure.
But less
So it can be
studied, less properly studied, I think.
Yes.
Yeah.
Yes, more
Thank you.
applicable for fine needle aspiration.
Yeah.
Because we're afraid about the core material. Core material, very precious. If not treated gently, may disrupt the material. But it can be applied.
شكرا جزيلا. دكتور علي انا شويه يعني سوري not familiar with the setup بالعراق مال اي بس وحاول هوايه انه اسال على how can we help. It's interesting بالتوك مالته قلت لي statist let us down. بالسنتر مالتنا صار لنا حوالي 20 years we do e-bus. I think we never need an anesthetist in the room. We do it under light sedation. We never need an anesthetist to do e-bus. فاني ما اعرف هل هي مشكله بالسيت اب بالعراق او is it something we can help with او when e-bus itself is a very very safe procedure even with the bleeding. I think المشكله الوحيده يمكن from some of the presentations about trachea biopsy which we don't do. So we do node L4 R4. I do it weekly basis. But when I see tumor within the trachea, we always avoid it and go to rigid bronchoscopy surgeons, anesthetists. That's absolutely safe to biopsy station 7, L4, R4, R11, L11 on a daily basis. We never needed an anesthetist. So I don't know, هل هي مشكلة like anything new, who anxiety about it, or is it risk with the needle use? ما أعرف هي يعني it's something worth looking at.
يعني let me if I get the questions. And you mean you can't do it in just in the light sedation? Yes, I think you can. But what I work in the theater. So I prefer to have the anesthetist or at least the assistant with me. I try to avoid the cough because you know the cough during the bus it will be very nasty. And when we have everything is prepared, I prefer the anesthesia rather than the light sedation. Really, the seriousness of EBUS, as you say, is not so, but I am sure I have to work with under general anesthesia through rigid if I working by cryobiopsy.
Yes. But you use local fentanyl, لأنه it's absolutely tolerable.
Yes, yes. I sometimes just want to arrest the cough. But when I am in the theater and already the anesthetist is beside me, I think it's more easy. Okay, thank you.
Thank you for this.
Sorry, just one note about the doctor. Regarding the EBUS, you can do under conscious sedation, under deep sedation, under GA. It depends on which kind of the patient that you have. For example, in our hospital policy, we have to have an anesthesiologist with us. Whether we are even doing under conscious sedation, although we are doing most of the case under deep sedation. And regarding the setup, there is no problem with the setup at all. But there's one thing Dr. Ali mentioned regarding the anesthesiologist is whenever you have a central problem, whenever you have an hypoxia patient, most of the time, we will have some conflict with the anesthesiologist. Yes.
Absolutely. My point is about 95% of your patients don't need theatre, don't need anesthesia.
It's not regarding the theater, but this is a hospital policy because, you know, sometimes the patient will get hypoxia because we know that most of the patients that need an EBUS is not any young most of the time. It's an old one, you know, for staging, restaging. They're an old with different comorbidities. That's the point. Thank you.
We can chat later.
Yeah, of course. Thank you.
The last question from audience, and
Thank
after
you.
that we have question here.
Thank you for these presentations. I asked Dr. Amir and Dr. Ali Saleh, does the rose, it's not diagnostic by itself at the site of procedure. You can get the diagnosis later on. Ustad Ali Saleh, does the rose help you to minimize the complication and to decrease shortening the time of a procedure? And if can you assess the adequacy by yourself without the need of a histopathologist?
Definitely yes, it reduced the complication. ليش؟ أهم complication to me هي non-yielding procedure. فبالتالي يعني خلصت من هاي القصة. واحد اثنين I will reduce the number of passes. يعني أنا من سويت باس واحدة اثنين I got the diagnosis. أنا بعد ما راح أسوي باس ثالثة. واللي هي ممكن تخلق لي نوع من الcomplication. So it's reduce the complication. Does it affect the time? معظم الاستادي تقول تطول التايم. تطول التايم. لأن يبقى يقول لك أريد بعد أريد فور هيستو أريد بعد تطول التايم لكن على حساب الإفيكت. So I am very happy with it. يعني بهذا التطوال مال التايم very happy because it will increase the diagnostic yields. Can I do it by myself? I start to do it by myself but إذا حضر الماء بطلت التيمم من موجود الباثولوجيست بعد ما يحتاج.
I want to comment on this issue. One of the important limitation for the rose is the human resources. But if we decrease the threshold for the requirement of the rose, we can solve the problem. أنت ما تحتاج بكل الأحوال who experienced very efficient pathologist. You need adequacy, not diagnosis. So we can train some resident to do this procedure regarding the decision about the adequacy, not the diagnosis. So if you decrease the threshold, you can provide more human resources to apply ROSE on different disciplines, including EBUS, ROSE, and even finally any interventional procedure.
Thank you.
Thank you. We have a question here, please. After that, Dr. Mustafa, the last question.
Assalamu alaikum. Thank you for this informative session. حقيقة هو سؤالي كان الدكتور علي بس العفو الدكتور هادي فراح أنطيه الدكتور مصطفى أسأل بعد الدكتور هادي ما بالميديكال بلوروسكوبي it is always to induce this pneumothorax and if induced pneumothorax why you are using air not CO2 because air is very lead to very severe irritation to the pleural and may lead cause severe pain.
شكرا جزيلا للسؤال. الحقيقة هو صح ideally مكتوب بالكتب بأنه you are inducing pneumothorax by CO2 لكن احنا بالبراكتس وكل الأساتذة يسوونها منه ما تحتاج اصلا انت اول ما تفتح البلورا هو من كيف سبونتينيوس pneumothorax
لان هي نيجاتيف
بريشر وانت مرتاح جدا يعني
صحيح
بس في حاله واحده لما يكون اكو يعني اللانج سويت رابط لانج ما تصير بهاي راح تواجه مشكله حقيقيه.
As a surgeon we do release the adhesion by our finger.
By finger, yes. لما يكون small fusion او اكو adhesion that is you are afraid from injuring the lung by the forceps you are doing by finger لما تصل للبلورا تنفتح يدخل الاير. فبالحقيقه ابدا انا ما مستخدم والاساتذه كذلك ما مستخدمين السي او 2 spontaneous pneumothorax is enough for the procedure.
Thank you.
Sorry, just one note. As Dr. Mustafa mentioned, we are not inducing this CO2 really. In specific cases, what's called a dry pleuroscopy, when there's a very few amounts of the fluid, and sometimes it's indicated to have a pleural biopsy. Sometimes, then at that point, we can induce a normal saline. I think normal saline, it works much better than the air. But there's a few centers this center in the Turkey, I have been there. They're inducing a lot of air. Most of the time, this is the protocol. But normal saline for the very few effusion, for the dry fluoroscopy, it works very well, fantastic.
Thank you.
إضافة أخيرة للأستاذ حسين إنه مرات يستخدمون الأوتو نفسه هذا الأكسجين مالتنا اللي مال البيشنت نفسه نخليه بالتيوب عند أكسجين ولا انتر عند إكسباند الآن بس أكل الرير كونديشن حقيقة. شكرا جزيلا.
شكرا يا اساتذتنا. سؤال اخير هو قبل ان نختم الجلسه الاستاذ مصطفى. Regarding the central airway obstruction, if there is any bronchoscopic features to predict failure of complete recanalization?
Yes. If the track is long about the tumor, يعني when you see the tumor, you cannot pass behind the tumor by the scope or by the catheter. This means a long track of tumor, and the debulking will be very difficult or traumatic to the patient and may fail. Therefore, you have a bronchoscopic picture. ما صار عندنا وقت نحكي عليها. إذا كان pedunculated, it is very good. إذا كان large, it is less good. And if it is long tract of a tumor, يعني صار filtration for مثلا 5 cm or more, it will be impossible تقريبا to recanalize.
عشان استاذ الراديولوجي وحده ما راح يحدد السكسس. الراديولوجيكال بيكتشر ما راح يحدد.
It will help أكيد. It will help. It will help.
عاشتكم اساتذتنا. احنا حقيقه جدا فخورين بوجود الاساتذه اللي بدوا يعني حقل الانترفنشنال بالمونولوجي وتعقيبا على السيتنج مع دكتور رشاد زميلي وكليه بغداد كليه طب بغداد وبعدين عافنا وراح لبريطانيا. تعقيبا على السيتنج مال الجنرال انستيزيا هو احنا حقيقه نبدي شوي شوي ان شاء الله. لو ما وجود اساتذتنا اللي حققوا الانترفنشنال بالمونولوجي ممكن احنا ما نخطى هاي الخطوات. احنا يعني فتحوا لنا الطريق، فتحوا لنا النور حقيقه وكلش يعني شكورين وفخورين بوجودهم ان شاء الله، وان شاء الله نكمل الطريق وياهم. فان شاء الله السيتنج اللوكال وهذه ان شاء الله نحققها ان فيوتشر ان شاء الله. شكرا جزيلا. شكرا جزيلا سعد.
شكرا جزيلا. شكرا. ولو طول السيشن اكثر من اللازم بس شو نسوي؟ Next session about COPD. تفضل الاستاذ الدكتور عبد الحميد القصير. استاذ الدكتور عمار قاسم. This must be limited with the time extended. عندنا 7 جلسات اليوم احنا و11 بالليل.
Assalamu alaikum. Our next session about a very important subject, COPD. It is the third cause of death all over the world. We will start our session because of the sake of the time with an international speaker. He's waiting for the last 1 hour for us and he is very busy. So we will start with this session and the review with the virtual, and we have about half an hour for this discussion, for this presentation and discussion. Good morning. I think in UK it's still the morning. Do you hear me?
I can hear you. Can you hear me?
Good morning, sir.
Good
Professor
morning.
John Hertz, Professor in Respiratory Medicine, Vice Dean of International Relation with Faculty of Medicine, Scientific University of College London, UK, and he will talk about a very important subject, what COPD and cardiopulmonary narrative. And you know that this is a very important subject nowadays, and we hear and thank you for joining us. And we are apologize about this delay because we have a very beautiful and very heavy program. Thank you, sir.
Shukran. Salam alaikum. I guess it's just between good morning and good afternoon in Iraq. But thank you very much for the invitation to speak with you today. Thank you for the kind introduction, and it's my pleasure to speak about something which I think we're going to be hearing a lot more about over the coming years, and that's this issue of cardiopulmonary risk in people with COPD. First of all, a disclosure slide and an acknowledgement slide. But in terms of what I'd like to cover over the next 20 minutes or so, there are really three topics, I think, that we need to consider together. First is a definition. What do we mean when we talk about cardiopulmonary risk? I know that some of you will be familiar with that as a concept already, but for some of you it may be new. So let's talk a little bit about what that means. And having defined cardiopulmonary risk, we should go on and decide together why we think cardiopulmonary risk is important, what are the mechanisms driving cardiopulmonary risk, and how can we assess it, and how can we modify it. So that's the plan going forwards. But I'm actually going to start with something very basic, and that's the idea that we've known for centuries that there are interactions between the heart and the lung. We need both our cardiovascular and our respiratory systems functioning together to ensure adequate tissue oxygen delivery. And of course, the heart and the lungs share space within the thorax. So perhaps it's not so surprising that there are interactions between the heart and the lung. What's new, though, is our justification for thinking about these interactions as one. And this slide summarizes some of the things that we're going to go on and look at in a little bit more detail over the next 15 minutes. So first, at bottom left, we know that respiratory and cardiovascular events are both very common causes of death in people with COPD. We'll look a bit more in detail about that afterwards. And a plausible mechanism linking COPD and cardiovascular disease are exacerbations, because we know the risk of cardiovascular events is increased in the period following an exacerbation of COPD. And lastly, and again we will return to this, there's some biological plausibility here in terms of mechanisms. And I think the key mechanisms are going to be around inflammation, hyperinflation, and hypoxemia. So this is a summary slide of the rationale for thinking about the heart and the lungs together. And the way we do that now is in this context of, or this concept of cardiopulmonary risk. And here's a definition of cardiopulmonary risk. It's defined as the risk of serious, meaning hospitalized, respiratory and or cardiovascular events in people with COPD. So that includes COPD exacerbations, of course, but it also includes cardiovascular events including myocardial infarction, stroke, arrhythmia, acute decompensations of heart failure, or death due to any of those things. So when we're talking about cardiopulmonary risk, that's what we're talking about. Serious respiratory and cardiovascular events in people with COPD. Well, so much for definitions. Let's go on and think a little bit about why it's important. Well, I think all of us working in pulmonology and thoracic surgery, in internal medicine and in primary care, recognize that many people with COPD, if not the majority of people living with COPD, are also living with other long-term conditions. We can use different language for that. We might say that people with COPD have comorbidities, or we might say that COPD is a common component of multimorbidity. Now, the prevalence of those individual comorbidities is going to vary a lot between different studies, depending on what cohort has been studied. But in general, the commonest ones are hypertension, perhaps almost 50% of people with COPD having hypertension, and as you can see on the screen here, coronary artery disease, 40%. So these are very common. It's very common to see people with COPD living with other things as well. But it's important because it tracks with mortality, and this is an important slide. The two bars on the left are people with moderate COPD, and on the right we have severe and very severe COPD, meaning gold stage 3 or 4. And on the y-axis we've plotted the percentage of total mortality. Well, let's look at those with severe and very severe COPD first of all. In the blue are the respiratory-related deaths. And you can see that respiratory-related deaths, as you might expect, are the commonest cause of death in people with severe and very severe COPD. So by that we mean hospitalized exacerbations, respiratory failure, cor pulmonale, these kind of things. Notice though that in the people with moderate COPD, that's the left two bars, the greater proportion of death is cardiovascular related and not respiratory related. And of course there are more people living with moderate COPD than there are with severe and very severe COPD. So if we're really going to want to transform COPD outcomes, particularly in those with more moderate airflow obstruction, we need to be holistic. And we need to be thinking about cardiovascular risk in people with moderate COPD. We're going to talk a bit more about exacerbations, but a bit more about mechanisms, sorry. But exacerbations are certainly a plausible link between COPD and cardiovascular disease. What we've done here is plot the hazard ratio on the y-axis of these different cardiovascular events in the 14 days following a COPD exacerbation. So you can see the risk of an acute coronary syndrome is doubled over that period, almost a 3 times risk of increased admission with heart failure or with arrhythmia, and a suggestion of an increased risk of stroke too. Now, that risk is durable, it lasts a long time, and that risk is also dependent on the severity of the exacerbation. Let me show you what I mean. So here's what the risk looks like in people who've had a severe, meaning a hospitalized COPD exacerbation. The risk of a severe cardiovascular event or death is 20 times higher in the first 7 days following a COPD exacerbation than it is in COPD in the stable state. So a significant increased risk of cardiovascular events following a hospitalized COPD exacerbation. That risk is highest earlier, but note that that risk is still significant up to 1 year after that hospitalization. So increased risk, and that increased risk persists. Well, so much for severe COPD exacerbations. Let's look at a similar figure next for moderate, meaning community-treated exacerbations. 2 things to notice here. The absolute risk is not as high. So where it was 20 times higher in the first 7 days following a severe exacerbation, now it's only between 2 and 2.5 times higher. Still significant elevation, but not to the same degree. And also notice that the risk is prolonged again, but here prolonged only to about 6 months. So even moderate COPD exacerbations are associated with increased cardiovascular risk, highest, earliest, and persisting up to around 6 months. When it comes to mortality following a COPD exacerbation, we're used to the idea that the greatest mortality is in the severe exacerbations, and that's the figure on the left here. So fewer than 50% of people will still be alive 4 years after a severe COPD exacerbation. And often we focus on those hospitalized exacerbations, but we mustn't forget the increased risk of death associated with moderate COPD exacerbations. So a 17% increased risk of COPD-related death, a 23% increase of cardiovascular-related death, even following a moderate community-treated COPD exacerbation. Let's put some of that together next in this diagram. Where there are strong associations with substantial data, then I've drawn a solid black arrow. Where there's less data, where there are emerging associations that might be important but probably need more data, we have a dotted arrow. So what can we learn from this? Well, let's start on the left with COPD exacerbations. And we've known for a long time now that the best predictor of future exacerbation risk is past exacerbation history. That gives us a concept of a frequent exacerbator, which has been established within GOLD guidelines now for a long, long time. Notice also, though, at the top and with a strong arrow, meaning that there are significant associations with lots of data, that symptoms also predict the risk of exacerbations. So risk of COPD exacerbations are higher in those with increased breathlessness and frequent productive cough. Now, exacerbations are bad news. I think this audience doesn't need to be reminded of that, I'm sure. Exacerbations irreversibly reduce lung function, each exacerbation resulting in a stepwise decline in FEV1. We've already talked about the idea that a past history of exacerbations predicts future risk, and importantly, and again with a solid arrow because the data are robust, exacerbations have an impact beyond the lung. And we've already looked at that in relation to the increased risk of cardiovascular disease. So, for both of those reasons, COPD exacerbations themselves and those cardiovascular events, there's increased risk of what on the slide here is labelled as early death. Perhaps, though, we should change the language and we shouldn't be talking about early death. If we start calling that preventable death, if we start calling that avoidable death, perhaps that's more of an impetus for us as clinicians to think about how we can mitigate cardiopulmonary risk burden in people with COPD. Because I still think that COPD is often being managed as a single disease state. Pulmonologists are just focusing on the lungs. And actually, we need to move to a position at the bottom where healthcare professionals consider COPD as a multi-morbid disease that's associated with major adverse cardiovascular events, MACE, and indeed major adverse cardiorespiratory events. It's not new, right? I mean, we've been talking about this for some time. This is Barcelli's famous diagram from more than 12 years ago now, where he introduced the concept of a comorbidome. To remind you, this is a group of comorbidities in people with COPD. The bigger the circle, the more prevalent the comorbidity. And you can see in the key there, the size of a circle that represents 50% prevalence. And he color-coded the comorbidities by system, so the red ones are cardiovascular disease. And then everything within that black dotted line was significantly associated with death. So you can see, again, the burden is cardiovascular disease with coronary artery disease, the most prevalent comorbidity statistically associated with death. So we have known this for a long time, but perhaps the language that we use is changing. I've already explained the concept of cardiopulmonary risk. That language has only been around for a few years now. And also we have the language of syndemics, the idea that COPD is probably best considered a multi-morbidity state, with COPD just one component of that. Okay, so we've defined cardiopulmonary risk and we've looked at why it's important. It's important because it's killing people. What can we do about that? So we need to talk in this last section then about the mechanisms, about how we can assess cardiopulmonary risk, and about how we can mitigate and reduce cardiopulmonary risk. Well, let's think about mechanisms first. And at the top right, we can think about shared risk factors. Clearly, COPD and cardiovascular disease share the idea that there are exposures, cigarette smoke exposure, for example, also indoor and outdoor air pollution, and they're both a condition associated with aging. It may also be relevant to think about lung function trajectories in childhood. So there are definitely shared risk factors and pathogenesis. And we're used to those shared risk factors leading on to COPD, top left, and the characteristic COPD pathophysiology, inflammation, hypoxemia, and hyperinflation. Those shared risk factors also lead to cardiovascular pathophysiology and to cardiovascular disease, but so far we have two separate parallel systems. Notice the arrow right in the middle here, linking respiratory pathophysiology with cardiovascular pathophysiology. That's the important thing. What's driving that? Well, I think three things are driving that. COPD is defined in part by airway inflammation. We know that's also associated with systemic inflammation. And of course, systemic inflammation is a major driver of atherosclerotic cardiovascular disease too. Hyperinflation, I think, is another important mechanism. Static and dynamic hyperinflation are absolutely the pathophysiological hallmark of COPD. And hyperinflated lungs compress the heart, compress the great vessels, embarrass cardiovascular function. And lastly, at least in more severe COPD, I think that hypoxia is likely an important mechanism as well. Two more things to notice on this slide, having said that there are three important mechanisms. One is that all those mechanisms are tractable. They're all treatable. If we're going to start thinking about inflammation, then that means anti-inflammatories might be effective. If we're thinking about hyperinflation, then bronchodilators might be affected. If we're hypoxemia, we can treat that with oxygen. So all those three mechanisms are tractable. Notice also that all those three mechanisms are exaggerated at the time of a COPD exacerbation. So a COPD exacerbation has more inflammation, has more hyperinflation, has worsening hypoxemia, and that may well be explaining the link between COPD and cardiovascular disease. So how to assess it? What should we do? Well, there are lots and lots of different ways of assessing cardiovascular risk. We can think about risk scores, we could think about blood biomarkers, we could think about CT coronary artery calcium scoring, we could think about ECGs, we could think about lots of things. At the end of the day, it actually matters. What I do think matters is actively doing this. So in other words, that for all people with COPD, we should be thinking about their cardiovascular risk. Lots of risk scores around. We've got lots of risk scores that we might use in COPD, so Bode index, for example. And we've got risk scores that think about cardiovascular risk. So commonly used in the UK in primary care is a risk score called QRisk or QR. And actually that's just been updated and now includes COPD as a specific variable associated with risk. There might be an argument that we need a new tool to predict cardiopulmonary risk, but at the end of the day, we've got a lot of scores that we can use. I think if I've got one practical tip that I want to share with you today, it's this, is that as pulmonologists, we should always be considering cardiovascular risk in people with COPD. And so we should be looking for, assessing and putting in place plans to mitigate cardiovascular risk factors. Simple way of thinking about that perhaps should be as interested in the person's blood pressure as we are in the oxygen saturations. That's certainly how I practice in London. I'm trying to be holistic and thinking about these multiple long-term conditions. I'm not managing everything myself, but at least making sure that the person is being seen by a cardiologist if they need a cardiologist, or indeed in primary care, because we've got very strong primary healthcare systems in the UK. Okay, so let's think lastly just a little bit about the future and what GOLD has to say. Well, the GOLD 2025 guideline was released just about a month ago, but 2023 saw a big change in GOLD. And GOLD had an increased focus on mortality reduction using pharmacotherapy. And it was able to say that because of two landmark studies that I'm sure you'll be familiar with. One was called IMPACT, one was called ETHOS. And although they used different molecules and different devices, both those landmark studies compared a single inhaler triple therapy against a LABA-LAMA and against an ICS-LABA. And both have very similar results. These are the exacerbation results, which were the primary endpoints of both. And in both cases, the single inhaler triple therapy reduced the exacerbation rate compared to the LABA-LAMA and compared to the ICS-LABA. So far, so good. But more interestingly, both of those studies had mortality as a secondary or pre-planned endpoint. And both those studies also showed a significant reduction in all-cause mortality with the single inhaler triple therapies compared to the LABA-LAMA. And that leads to the interesting question of what the mechanism of that mortality reduction is. I think when you first hear about this, you kind of say, well, single inhaler triple therapy reduces exacerbations. Exacerbations kill people. And so by reducing exacerbations, there's a reduction in death. And that's true, but it's not the whole story. Because again, for both of those studies, there seems to be a reduction in cardiovascular death in relation to single inhaler triple therapies. And excitingly, we have more data coming with this ongoing study called THAROS that some of you may well have heard of already, currently recruiting, testing the idea as a primary endpoint that single inhaler triple therapy can reduce cardiopulmonary events. So as I come to the end of my time with you today, In summary, it's clear that COPD independently elevates patients' risk of cardiovascular disease, and therefore there's a rationale for considering cardiovascular events and respiratory events together as cardiopulmonary risk. That's defined as the risk of serious, meaning hospitalised, respiratory and/or cardiovascular events or death in people with COPD. And identifying this, mitigating it, and treating it is important, because if we don't do that, we are not serving our patients in the way that we would want to, and patients are having avoidable, preventable early death. Shokran, pleasure to be with you from London today, and it will be a pleasure to answer any questions that you may have. Thank you very much for the invitation to be with you in Iraq.
Thank you very much about this very interesting subject, Mr. Professor John Hertz. We have 5 minutes for a question, please, and he is still in live with us virtually. Can I ask you one question, sir?
Of course.
You say that the severity of exacerbation have more burden on the disease and the prognosis, severity rather than, and we think that from the new guideline, we can start triple therapy to reduce the risk. How you explain, my question, explain that those with the moderate disease, they have more cardiac risk or more cardiac death rather than those who have approximately severe disease, that the cause of death will be respiratory and pulmonary.
Yeah, and there's a third cause of death which wasn't on those slides, which we also need to remember, and that's lung cancer. So lung cancer is common both in moderate COPD and severe and very severe COPD, and that's obviously important to an audience of pulmonologists and thoracic surgeons. So we should think about lung cancer risk too. I guess I'm not surprised by the data showing that cardiovascular death is more common in people with moderate COPD. If you have moderate COPD, the chances of dying from an exacerbation are much, much less than if you've got severe COPD and very severe COPD, because you have more respiratory reserve. So it's unusual for people with moderate COPD to need to be hospitalized for COPD exacerbation. Although they get worse, they don't get so worse that they have respiratory failure, need NIV, intubation, all these kind of advanced therapies that we do. So relatively speaking, the cardiovascular events are more important. I think, though, unless we're being holistic, unless we're thinking about everything together, about how we can reduce cardiovascular risk, how we can improve COPD outcomes, and indeed being alert to the possibility of lung cancer, then we are missing the opportunity to do the best for our patients. Thank you for your question. It's a good one.
Thank you. Dr. Cameron. We have another question from Professor Cameron from Iraq.
But you know, dear, about 65 to 70% of moderate COPD undiagnosed over all the world. It's maybe at the time of the exacerbation and cardiovascular events, at the time of these events, we are coming to diagnose COPD. We have many studies, and you know, I am sure, this is the weak point in our investigation. I have gone through many articles how we can avoid these events. And they recommended that all GP, all these medicines, something like that. We have general practitioner, we have something else. They recommended to buy spirometry on their outpatient clinics, not just pulmonologists, because they recommended that to diagnose moderate COPD from the primary doctors to refer to the pulmonologist or something like that. So this weak point, still I didn't hear from your talk how we can choose, how we can solve this problem, because this is not the first time we heard moderate COPD, about 65, 70% undiagnosed. That's why this weak point, I didn't hear from your talk how we can solve this problem. Thank you very much.
Thank you for your question, and it's such an important point. So this is true wherever you work in the world. So here in the UK, for example, a relatively well-resourced healthcare system We have about 1 million people diagnosed with COPD, and modelling would suggest that there are 2 million more who don't have a diagnosis. A big charity in the UK calls those the missing millions. How do we find them? Because they're not coming to us as pulmonologists, right? They're not sufficiently symptomatic to come through to a pulmonologist. And so if we really want to address the challenge of finding these people with more moderate disease, we need to be taking our message out to where these people are. And these people are in primary care. So yes, we need to be educating primary care practitioners about the importance of finding people with COPD, spirometry perhaps, but also there are screen questionnaires that can help to identify people who really need spirometry. So the CAPTCHA questionnaire, for example, by Fernando Martinez, and there are others as well. But we also need to take this message to our friends and colleagues, the cardiologists, because a lot of these people will be in cardiology clinics as well. So maybe we should be thinking about case finding for COPD in people who've had a heart attack or a stroke or been admitted with or have problems with ischemic chest pain. So because these people aren't coming to our front door, as a pulmonologist, they're not coming to our office and our clinic, we need to take our message elsewhere. So that is a really, really important question, and it's a big problem all over the world.
Thank you very much about this information. We hope that we will see you again, sir, and we are very happy to join you because of the sake of time, and we know you are busy, and thank you again and again, and thank you for AstraZeneca for preparing this virtual meeting, virtual lecture. Next speaker, shukran jazilan, shukran, thank you. Next speaker is Dr. Ammar, consultant pulmonologist في مستشفى مدينة الطب, وهي is now حقيقة عضو هيئة تدريسية في كلية الطب بغداد, غني عن التعريف, about update in COPD, and his subject is very interesting. He is saying updating of 2024, but now the issue of 2025 had been emerged now.
راح أقدم محاضرتي أنا وبعدين. من يدبرها؟ لا بس
بالحقيقة he had two talk دكتور عمار.
I had two lectures.
راح اثنيناتهم ويا مال
راح اسويهم محاضرة واحدة.
ممتاز.
وراح اخلي بس يعني حاولوا تركزون, حقكم تعبانين واغلبكم جايين من السفر.
نعم.
فنحاول ان يعني نركز.
نعم.
بس
ان شاء الله.
افتح لي الفلاش مالتي. لا هسه راح نقدمه ورا هذا. راح اقدمه بس طلع لي محاضرتي اللي موجودة بالسيشن الثاني. هذه عاشت ايدك. بنخلص هاي نرجع ليش. بس طلع لي لا ذيك. اي طلع لي اياها. هاي شكرا جزيلا. كل احنا عندنا اسئله وجاي ارتكلز يوميه تنزل على السي او بي دي. سي او بي دي نعرف انه ذا موست كومن كرونيك illnesses, وبيها يعني ابلكيشن هواي راح نحكي شي بعد. شكرا جزيلا. فنحاول بس شنو الجديد اللي صار بجولد، شنو الشغلات الجديده ب 24 اختلفت عن 23. The 2024 update in COPD management as outlined by Global Initiative for Chronic Obstructive Lung Disease includes several key changes. شنو الهدف من أنته؟ For prevention, to improve diagnostic field and improve treatment. اللي صار شنو؟ كان عندنا level C و level D. بالمانجمنت تغيرت إلى level E. شنو الهدف من أنته؟ The A and B group still unchanged, but the B, C and D group are now merged into single group termed E to highlight the clinical relevance of exacerbation. البيشنت كان بالجروب C والجروب D اي بيشنت تو اكسبت مور يتخلى بالجروب سي ودي. اذا الام ار سي مالته لو يتخلى سي، واذا هاي يتخلى دي. هسه مزجت سويه صارت جروب واحد. This approach also aid in tailoring therapy more effectively. بالفارماكوثيرابي the recommendation for initial treatment varies by group. Group A short or long acting bronchodilator هاي انحلت. احنا نعرف شنو الجروب A. الجروب B لابا زائد لاما combination as a preferred choice. الجروب E لابا and لاما with inhaled steroid considered eosinophil count more than 300. Notably, triple therapy is now recommended earlier in patients with high eosinophil count. Vaccination. Updated guidelines stress vaccination as an essential part of preventing exacerbation. Recommended vaccination include annual influenza, COVID, respiratory syncytial virus for individuals for more than 60, pneumococcal conjugate, and polysaccharide vaccine. سكرينينج هاي شويه يعني الحد الباحه انا اقرا عليها. السكرينينج ماكو شيء عليه كونترافيرسي بقد السكرينينج. انت اذا تجي وتخلي الناس تسوي لها سكرينينج اكثر من يعني 60 راح تلقى 20 25 30% من عندهم ابنورماليتي. هذول كلهم توديهم عمليات وتسوي لهم راح تسوي اندوس مور هارم مور ذان يور بنفيت. فهنا انضافت annual low dose CT scan are advised for smoker. ممكن smoker incorporating spirometry to detect early stage disease. blood eosinophil count هاي قلناها قبل شويه. patient centered inhaler use. كل احنا عندنا كمل بالبراكتس. هذا البيشنت تستخدم له هذا الانهيلر يفيده، تستخدم له انهيلر ثاني ما يفيده. فمرات البيشنت اذا يجيك فيلر اوف انهيلر ثيرابي مجرد تغير له التايب مالته. It is emphasized the place in selecting inhaler based on patient capability, aerosol versus powder inhaler, and providing proper training using the teach back. يعني كل ما يجيك ترجع تدرسه من جديد. المريض ينسى ومرات يقول لك ايه تعلمت عرفت بس يريد يخلص من عندك من تشرح له. هاي اذا انت اصلا تشرح له. وهاي اطباء اصلا ما يشرحون الانهيلر مالتهم. روح له بالصيدليه هو يعلمك. عندي بحث منشور يعني هذا مسوي بال 2012 80 85% بالمرضى بالعراق على الاقل بالستدي مالتي ما يعرفون يستخدمون البخاخ بصوره صحيحه. فخلي هو اهم شيء انت ايش عندك غير البخاخ؟ اهم شيء انت تعلم البخاخ وكل ما يجي تعلم البخاخ من جديد. You will improve the prognosis and control of your patient. This ensure effective use and reduce medication error. Chest imaging. It is not essential for diagnosis. Chest CT is recommended in patients with persistent exacerbation for planning intervention like lung volume reduction surgery. This update aims to enhance personalized care, reduce exacerbation, and improve overall patient outcome. محاضرة قصيرة بس أعتقد يعني إذا مركزين وياها أحسن ما نطول فترة طويلة. نحول على المحاضرة الثانية اللي هاي أنا مكلف فيها من شركة عبد إبراهيم. وين ال بس اعطيني مجال انت اللي تعرف I know thank you. What's new in COPD? COPD يعني راح نرجع للبدايات. Chronic obstructive pulmonary disease is a heterogeneous lung condition. It is not one disease. It composed of chronic symptom. نقدر نعرف أن it's chronic symptom with dyspnea, cough, production, and or exacerbation. يعني مرات presentation بس just exacerbation. This is disease caused by abnormality in airway and addition to abnormalities in lung parenchyma. Existing COPD prevalence data vary. ما عندنا يعني حتى بالعراق ما عندنا national screening program. يراد لنا national screening program عن نعرف ايش قد البريفالنس مال disease. يمكن هواي كيسات مال COPD just treated as chronic bronchitis, just treated as asthma, just treated as heart failure. مثل ما قال الزميل من بريطانيا قال انه الكارديولوجيست حقيقه المريض بالعراق يمكن اغلب العالم اول ما يصير عنده مشكله بصدره يروح للكارديولوجي ما يجينا. فظلت عاد يم الكارديولوجي اذا يحاول عليك اذا شك انه عنده respiratory disease يرجع لك. Existing COPD prevalence vary Most national data show that less than 6% of the adult population have been told that they have COPD. This is likely a reflection of the widespread under-recognition and under-diagnosis of COPD. It is estimated that globally there are around 1 million deaths annually due to COPD. It is estimated that increasing prevalence of smoking in low-income country coupled with aging population in high-income country result in over 5 million deaths annually by 2060. هل هو السموكينج الوحده؟ لا. Smoking is important, but there is biomass exposure, there is poor population use still biomass, occupational exposure, air pollution. يعني اليوم ناس عندنا ببغداد ناس لا تدخن ولا تستخدم حطب ولا كل شيء وراح يصير عندهم COPD على البوليوشن اللي عندنا. اضافه اكو ناس تجيك هي اصلا بحياتها ما مدخنه، تجيك جينيتيك فاكتور عندهم الفا 1 انتي تريبسين ديفيشنسي. اضافه انه الادلت with asthma patient with asthma even if they don't smoke they have found to have 12-fold higher risk of acquiring COPD يعني more than people with not asthma. Chronic bronchitis range from 26 to 35 patients of COPD. Other factors associated with increased prevalence of chronic bronchitis include male sex, younger age, greater back year of smoking, more severe airflow obstruction, rural location, and increasing occupational exposure. Viruses, acrolein, cytokine can also increase this production. Pathophysiology هذا يعني مو وقتها مال pathophysiology بالمؤتمر واحد يقدمها. احنا هي composed of what? Airflow obstruction and gas trapping, pulmonary gas exchange abnormality, pulmonary hypertension اللي هو secondary to damage in the lung and secondary to chronic hypoxia, exacerbation and multi-morbidity. يعني مثل ما قال قبل شوية there is cardiovascular morbidity اللي هو correlates with COPD. How we diagnose? أول شيء clinical. The patient had dyspnea that is progressive over time اللي تفرق عن الديسنيا اللي بأسمى الأسمى is variable بينما بال COPD it is progressive over time, it's worse with exercise, it is persistent, it may be intermittent with unproductive. The patient had recurrent wheeze, recurrent lower respiratory tract infection. مرات the first hint that the patient had COPD يصير عنده دائما chest infection, recurrent chest infection. فلا بأس أن نسوي له chest X-ray, نسوي له spirometry، حشوف hyperflated chest وحشوف airway obstruction. إضافة أنه منو اللي أكثر اللي تدور عليهم هيك عندهم COPD اللي عندهم ريسك فاكتور، يعني السموكرز، الاوكيبيشنال دست اكسبوجر، the patient who has family history, low birth weight, prematurity, childhood, respiratory infection. شنو الديفرنشال diagnosis of COPD؟ هو الأسمة، congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis like a patient with rheumatoid arthritis and other disease, and diffuse bronchiolitis. هذني مرات differential diagnosis يراد لهن investigation و clinical examination و history to exclude، ومرات they are associated. الكارديوفاسكولار disease في كثير من الأحيان associated with COPD. Bronchiectasis it is a complication of prolonged run COPD. Patient COPD recurrent chest infection they are liable for bronchiectasis. نفس الشيء tuberculosis، نفس الشيء obliterative bronchiolitis. السبيرومتري هنا نشوف بالليفت سايد normal healthy individual. هنا شو نشوف؟ نشوف التوتال فورس فايتال كاباسيتي قلت، واللي النقصان الاكثر صار بالفيرست فورس اكسبيراتوري فوليوم فيرست سكند. فهذا الشيء يعكس الريشيو صارت اقل. هذا هو الكاركترستيك مال اوبستراكتيف ايروي اللي هو عاده شنو نفرقه عن الاسمه؟ it is not reversible. هذا نفس الشارت موجود بالاسمه، بس الفرق بيناتهم بالاسمه reversible after bronchodilator، بالسي او بي دي نوت ريفرسبل. الجولد يعتمد على السبيرومتري ريزلت. اي بيشنت الاف في 1 اكثر من 80 يعتبر مايلد، من 50 الى 80 يعتبر مودريت، السيفير ليس ذان 30، ال 30 تو 50 العفو، الفيري سيفير اقل من 30. الام ار سي جريد اتس ويل نون 0 1 2 3 4. بكل بساطه البيشنت كان هاف نو dyspnea less on sternus exercise labeled as 0 on يعني من يمشي ويا جماعته يتعب يصير level 2 بس من يصعد جبل يصير جريد 1 تل العفو، جريد 3 اقل من 90 متر او اقل من 100 متر، وجريد 4 dyspnea at rest. هنا الكات سكور. الكات سكور it is important سكور بس مشكلته under utilized. يمكن غالبنا واغلبنا ما يستخدمه ابد. المشكله ليش تصورون ما نستخدمه ابد؟ ليش ما نستخدم الكات سكور؟ كل احنا نعرف مهم وكل احنا قارينه. ليش ما نستخدمه؟ المشكله انه لازم مطبوع، يعني ما الواحد يتذكر هذني الفاريبلز كامله هاي يعني شبه مستحيله. فيمكن الطريقه ما طول موجوده الشركات اليدويه كامله وما شاء الله هم مستعدين يصرفون. لو يطبعوا لنا اياها هاي بحيث كل مريض نكتب اسمه عليها. الله يخليك.
اكو ترى عربيه، نسخه عربيه.
اي يعني حتى لو نسخه انجليزيه احنا هلا مو لنا هي يعني نسال المريض ونكتبها، وكل ما يجي كل زياره راح نسوي الكات سكور مالته تطورت لو لا. يعني هاي دعوه بلكي ان شاء الله نستغل المؤتمر نستفاد من عنده. هاي اللي قلناها قبل شويه وشرحناها، احنا قبل نعتمد على الجولد على ام ار سي زائد الاكساسربيشن سكور. من هالهوسه كلها الاهم شيء هو الاكساسربيشن اللي راح يخلي مور ذان تو اكساسربيشن تخلي المريض at level of E. الاي هو the most severe form. شنو التريتمنت اللي نستخدمها؟ البرونكو ديليتر. البيشنت يجيك هو ديسنيا ويجيك كف. شو يحتاج؟ يحتاج برونكو ديليتر. البرونكو ديليتر 3 انواع. الانتي ماسكارينيك، البيتا اورجانيست، الميثايل زانثين. البيتا والانتي ماسكارينيك بيها شورت اكتنج لونج اكتنج. نبدا نتدرج من الشورت اكتنج لللونج اكتنج. هاي بالحقيقه بالكيسات الاي والبي. بالكيس الاي راسا احنا نبدا من اللونج اكتنج، نادرا ما الشورت اكتنج تجيب نتيجه. انهيلد ستيرويد قد تدخل ضمن التربل ثيرابي ايضا، وقد تدخل جست ويا الانهيلد ويا البرونكو ديليتر.
2 minutes دكتور عمار.
ان شاء الله استاذ. احنا المهم ان الستدي تورش ستدي، هاي التورش ستدي سوت بهالقارات تشوفوها خلال 42 كنتري يعني 450 سنتر. هاي شنو الايم من تورش ستدي؟ يعني استخدموا different concentration of salmeterol with fluticasone alone, salmeterol بلاسيبو. شو ندور هنا؟ نشوف الابسوليوت ريدكشن ان ديث. وهاي برستيجيوس ستدي اخذت اعداد كبيره جدا مالتي سنتر، شافوا there is 17% absolute reduction in death. وين هذا الحكي؟ بالكومبينيشن اوف بوث، يعني اكثر من الستيرويد الوحده واكثر من السالمترول الوحده. دلالة الستدي it is to compare use of healthcare resources and COPD related cost of patient using salmeterol fluticasone combination. الدوز الجروب 1 فلوتيكازون لو دوز. الجروب 2 inhaled maintenance therapy inhaled corticosteroid لابا تايتروبيوم البترول combination. هم نشوف هنا there is 35% reduction. بوتيسينايد فورمترول with فلوتيكازون صار بيناتهم تنافس على النهائي. شلون ريال مدريد وبرشلونه؟ فهنا شو ندور على الكومبليكيشن. كل احنا نفكر شنو الكومبليكيشن اللي نشوفه احنا بالستيرويد. احنا ليش نخاف من الستيرويد ما نخليها بالسي او بي دي؟ خلينا نعطيهم كلهم من هيلد ستيرويد. هسه هو الكورنر ستون مال اسمه هو الهيلد ستيرويد. ليش احنا بالسي او بي دي نخاف؟ خلينا نختصر هاي المحاضره بهالكلمه. نخاف من النيومونيا. فهنا كوندك ذيس ستدي، وهاي الستدي يعني ماخذين الاف المرضى ومالتي سنتر وكذا. there is less pneumonia with this arm salmeterol fluticasone group. benefit of adding fluticasone. بيها benefit لو لا؟ The primary efficacy was pre-dose FVU and secondary endpoint include other measures. شنو اللي شفناه؟ there is سواء البرايمري او secondary both are better. نشوف multiple studies كلها تشوف انه الستيرويد inhaled steroid خصوصا بهالموضوع هذا بالفلوتيكازون it will improve prognosis, decrease mortality, improve FE1 and تقلل الريسك مال النيمونيا. هنا المشكله مالتنا شنو؟ واحد يقول لك انا شنطي سي او بي دي ودراي باودر انهيلر، على أي اساس؟ هو ما يقدر يجر نفس. وين يقدر يجر نفس؟ فهنا هاي الستديز شافوا انه even at low this is Q-haler. It is low resistant. يعني هو أصلاً مخليه مو high resistant. بقية الشركات ربما high resistant. It is a lower resistant group. فلهذا even patient اللي ال FV1 مالته قليل يستفاد من عنده. سواء فهذا شافوا result مالته it is better than other type of inhalers. It is يعني هنا هو هذا الدعاية مال الشركة بس الحقيقة هي مو شغل الدعاية. أنا for me it is my first choice to use. It is يعني easy. It is accessible. It is يعني حافظ على نفسه من الرطوبة اللي هي مهمة جدا. الرطوبة اللي باقي الشركات يمكن ما كلش مهتمة بيها تخلي prevent release of drug. And thank you very much.
Thank you very much, Dr. Ammar.
Thank you.
And we have
تفضل الأستاذ الدكتور أرشد فؤاد consultant interventional cardiologist cardiac electrophysiology MRCP assistant professor. تفضل إن شاء الله. About the burden of acute about the COPD and heart the serious realization. شكرا جزيلا.
هذه لك no just
لأنه راح يتعارض من البقية. لهسه تتعارض واقع الانتيموسكارينيك الزيد المورتاليتي. هاي بلشت عليها بس لا يبعد فينا بلشت عليه لأنه راح يطول ايزونوفيليا تسوي لها ما تطول بس راح انزلها بالموقع. راح انزلها بالموقع راح انزلها لأنه حكي
انت جربتها صح؟
حكيناها بس يعني ديتيل اكثر بس ما لها علاقه.
لا كان صح.
على الاضافه تخلي الانتيموسكارينيك بالعكس المورتاليتي راح تزيد بس راح انزلها.
اوكي نو بروبلم خليه على شو اسمه على المحاضره مالتكم موجوده باللابتوب. عليكم السلام يا مرحبا شلون صحتك؟ تمام. اوكي نو ماكو شيء. نفتح منها. نو اوكي. السلام عليكم. Sorry. Okay. Assalamu alaikum. I'm Dr. Rashid Fouad, interventional cardiologist and interventional cardiac electrophysiologist. It's my pleasure to be here to introduce my lecture, which is the COPD and the cardiovascular disease. I will continue the talk of Dr. John, Professor John, but here I continue my lecture on view from I will talk about from the cardiovascular view. So I will talk about the liaison between the cardiovascular disease and the COPD. Originally, I decided to ask you to download this app because there is a poll question at the end of the lecture, but unfortunately, my laptop is not working on this on the HDMI, so I will just skip this slide. I have nothing to declare. As you know, COPD is a chronic inflammatory disease, lines characterized by partially reversible airflow obstructions. But what do you think? What's the main cause of COPD death? Why patient with COPD died? The main reason of death is because of cardiovascular disease. Which diseases specifically in the cardiovascular system that lead to death of patients with COPD? Could be because of coronary artery disease. It could be also because of congestive heart failure. Could also because of cerebrovascular disease, peripheral arterial disease, and finally also because of arrhythmia, which could be linked strongly to the patient with COPD. How many times it is more common patients with COPD have a cardiovascular disease? What do you expect? It is 5 times more common patients with COPD have a cardiovascular disease. So it is a significant number. Why? What is the shared risk factor? It is mainly because of cigarette smoking, aging, environmental pollutants, sex, and diet. This is the shared risk factor between the COPD and patients with cardiovascular disease. Let's talk about the first disease, which is the coronary artery disease. Despite the sharing risk factor, which is the old age and the cigarette smoking between patients with COPD and coronary artery disease, it is not the main reason for the involvement with coronary artery disease. It found that there is a close relationship and there is a dose-response relationship between the forced expiratory volume in 1 second and the mortality in patients with cardiovascular disease. And according to the study, which is the lung health study, they show that the mortality is usually increased by 28% with each 10% reductions in the forced expiratory volume in 1 second. This is true also with the Renifro study, which found that patients with low forced expiratory volume in 1 second makes the patients at highest risk of death because of the coronary artery disease. So it puts it at the top of this of the cardiovascular risk for death. And they found that, according to the epidemiology, that coronary artery disease usually occurs 2 to 5 times more common than in patients with the general populations. So patients with COPD have 2 to 5 times evidence of coronary artery disease more frequently than in the general populations. Also, we have still a confusing thing. The symptom is still confusing because we have still a sharing symptom between patients with cardiovascular and COPD. It is mainly dyspnea and chest tightness. There are shared symptoms in patients with COPD and patients with coronary artery disease. Second disease is congestive heart failure. The same is true. We found that patients with poor lung function is also a risk factor for incident heart failure, and that the low ejection fraction is associated with an increased risk of hospitalization because of heart failure. And still, 1/5 of patients with COPD still not diagnosed as having heart failure. And the overall prevalence of heart failure in patients with COPD is ranging from 12 to 55%. This is the same is true for what? For the diastolic heart failure. The prevalence of heart failure with a preserved ejection fraction is approximately 5% in patients with COPD. So it is a big problem. What are the common cause of heart failure regarding in patients with COPD? It is still the coronary artery disease is the leading cause of heart failure in patients with COPD. And still we have a confusing thing, which is what the sharing symptom. Patients with COPD and heart failure have a sharing symptom, which is mainly cough and wheezing. And still also nocturnal cough and paroxysmal nocturnal dyspnea still occurring in both diseases, patients with COPD and patients with what? With heart failure. Regarding the third disease, which is cerebrovascular accident, still multiple epidemiological studies found that there is an inverse relationship between forced expiratory volume in 1 second and what? The ischemic stroke. And according to the Copenhagen study, they found that ischemic stroke increased by at least 5% for each 10% decline in the forced expiratory volume in 1 second. Regarding the fourth disease, which is the peripheral arterial disease, also there is a link between the peripheral arterial disease aortic aneurysm with COPD. With the small studies found that 1/3 of patients with COPD still have a peripheral arterial disease. The same is true also for the arrhythmia, which is the fifth disease. Supraventricular and ventricular arrhythmia both common in patients with COPD. And the multifocal, the MAT, is almost exclusively present with COPD. This is special arrhythmia found in those special population. If we apply a 24-hour Holter monitoring for a patient with COPD, what do we expect? We expect to find that there is supraventricular arrhythmia, ventricular premature beat, ventricular bigeminy, and also non-sustained VT. And also still the low forced expiratory volume in 1 second is still linked to the incident atrial fibrillation with a high prevalence. What about the diagnosis? Patients with COPD could consult cardiologist and also could consult the pulmonologist. So patients with COPD and cardiovascular disease could be seen by both cardiologists and pulmonologists who frequently miss the diagnosis that does not belong to their specialties. Always we look to our specialties. We are not looking to the other side of the cube. So this is both due to lack of the awareness as well as the substantial overlap in the symptom. As we see, there is an overlapping symptom between patients with COPD and those with coronary artery disease or with heart failure. What should be best done in COPD patients with dyspnea and chest tightness regarding the diagnosis? As I said, I'm talking about COPD patients and heart and cardiac disease from the cardiovascular prospect, from the cardiovascular view. So from my view, I want to set for ECG, troponin, N-terminal proBNP, echocardiogram, chest radiograph, and the butamine stress test. So I need to do ECG, EKG for the patients, troponin, N-terminal proBNP. But keep in mind that the N-terminal proBNP could be elevated in heart failure and also where in pulmonary hypertension. So it could be elevated in both conditions. Echocardiogram is also important. Chest radiograph, the butamine stress test. But why the butamine stress test, not exercise tolerance test? Because of dyspnea. Usually there is exercise limitation in patients with COPD. That is why we prefer as a cardiologist to do the butamine stress test rather than the treadmill test. What about the contraindication to the vasodilator radionuclide myocardial perfusion scanning? It is because of the bronchoconstriction that occur with this imaging in COPD patients. That is why it is contraindicated. Treatment, what is the treatment? Stop smoking, and stop smoking. This is the most important thing. Advise your patient, almost always, me as a cardiologist, you as a pulmonologist, advise your patient to stop smoking. Second is pulmonary rehabilitation. Third is vaccination. Fourth is long-term oxygen therapy. And finally, we have the non-invasive positive pressure ventilation. Stop smoking is very important, as we said. Second thing is pulmonary rehabilitation. It is found that there is significant improvement in dyspnea, respiratory quality of life, and exercise capacity. It is independent of how severe your lung disease. So very important is the pulmonary rehabilitation. And I think most of the center is lacking in our country pulmonary rehabilitation, right? We don't have actual pulmonary rehabilitation.
board مال rehabilitation هسه وقلنا لهم يخلون كورس مال respiratory يعني ان شاء الله it will be functioning.
Yes. The second non-medical therapy is vaccination, which is very important to take annual vaccination regarding the pneumococcal and regarding the influenza vaccine. Long-term oxygen therapy, as indicated by the pulmonologist, and finally, non-invasive positive pressure ventilation. As we said, my lecture is mainly from the cardiovascular review, not from the pulmonary review. So how we treat patients with COPD? How do we treat COPD in patients with cardiovascular disease? It is the same as without cardiovascular disease. So treat patients with COPD with or without cardiovascular disease in the same manner. How we treat cardiovascular disease in patients with COPD is also the same, but except for the non-selective beta blocker. That should not be used due to bronchoconstrictions. So it is almost the same except for the non-selective beta blocker. So why non-selective beta blocker shouldn't be used in patients with COPD? As we said, because of bronchoconstriction. But do we have alternatives? The answer is yes. We should use cardioselective beta blocker in the form of atenolol or metoprolol to be safer in patients with COPD. This is the same true as for the long-acting anticholinergic. It is the preferred over the short-acting. Why? Because they found that there is less arrhythmia risk in patients who taking the long-acting anticholinergic like tiotropium regarding with patient who's taking the short-acting one, especially regarding the arrhythmia in patients with cardiac disease. This is my poll questions. I intend to make you answer on these questions at the final of the lecture, but unfortunately my laptop is not working. My question is, what about the spirometric confirmation of airway obstruction in patients with pulmonary edema? He had a heart failure and a severe heart failure with pulmonary edema. So which is the time best to do the pulmonary function test in patients with pulmonary edema? Is it at the same time? Is it after giving bronchodilator? Is it after giving anti-failure therapy? Is it when the patient is eovolemic, or even after giving oxygen therapy? This question I intend to not to assess your knowledge. I know your knowledge, but just to make the lecture is interactive. I will answer these questions. The best answer is here is when the patient is eovolemic. Not immediately, not after giving bronchodilator, not after giving anti-failure therapy like Lasix, not after giving oxygen therapy when the patient is eovolemic. Because when there is pulmonary edema, there is also bronchial edema, usually lead to bronchoconstriction. So usually this will lead to failure to assess the proper pulmonary function test in patients with pulmonary edema. So the proper time is when the patient is eovolemic. So thank you for your listening.
Thank you very much. Elegant presentation, and we thank the cardiologist برئاسة جمعية القلب دكتور مثنى على هذا السبورت for this lecture and for this information. Next, Dr. Osama, Board of Internal Medicine, and the final for subspecialty of respiratory مستشفى اليرموك التعليمي. He will discuss a very important subject on changing our mind of treatment of COPD and the burden of acute exacerbation on the course of the disease and the prognosis of COPD. I think you have less than 10 minutes to go. Thank you very much for joining us.
Assalamu alaikum. My lecture, the burden of acute exacerbation on the patient with COPD. As you know, the exacerbation of COPD characterized by worsening the symptom already the patient has, the worsening of cardiopnea and sputum production beyond normal day-to-day variation. Acute exacerbation of COPD are major cause of hospitalization, healthcare cost, morbidity, and mortality in COPD. These are symptoms of patients with COPD. If this increased symptom by infection or another thing, it is called exacerbation. The main contributor to be considered in patients presenting with suspected COPD, according to the last guideline, 2025, we put pneumonia as most differential diagnosis of acute exacerbation, pulmonary embolism, and workup, heart failure, pneumothorax, pleural effusion, and myocardial infarction or arrhythmia. It is very important to put in differential diagnosis of acute exacerbation. Classification of severity, in our emergency unit in ER, it is mild, moderate, severe, according to the vital signs, and CRB very important and available in all our hospital. If the CRB more than 10, it is moderate. Is less than 10, it is mild. And also sent for ABG, if the patient pH less than 7.35, it is very severe acute exacerbation of COPD. طبعا احنا هنا البوتنشال indication according to the last guideline for hospital assessment if there is severe symptom, the acute respiratory failure, if new physical sign, and failure of treatment or the initial treatment. The key point in the management in exacerbation, it is short-acting inhaled beta agonist with or without short-acting anticholinergic. It is the main treatment of patients with exacerbation.
Another one, systemic corticosteroid improve lung function in the patient with the COPD, but not normally more than 5 days, only for 5 days corticosteroid. And antibiotic, when indicated, also only for 5 days. Methylxanthine not indicated according to the last guidelines in the patient with the COPD, and also evaluation for non-invasive mechanical ventilation. According to the medical intensive care unit, if the patient deteriorated, not responding, pH low, this is admission for ICU. And in indication for invasive mechanical ventilation, one of the following. Main thing, it is respiratory acidosis. When the pH less than 7.35, severe dyspnea with sign of respiratory muscle fatigue or persistent hypoxemia despite the supplemental oxygen therapy. The indication for invasive, the same of the previous guideline, and discharge criteria for patient for the acute exacerbation. عندنا yearly follow-up and late follow-up. Early in 1 to 4 weeks, والlate follow-up after 12 to 16 weeks. مثل ما قال أستاذ عمار قاسم إنه لازم according to the patient inhaler technique, physiotherapy, stop smoking. This is very, very important to patient improve condition and to prevent further exacerbation. According to the last guideline, what is the intervention that reduce frequency of exacerbation? The main thing, it is a bronchodilator and the corticosteroid and the anti-inflammatory, and the new guideline added dupilumab with the intervention that reduce exacerbation. And the anti-infective, azithromycin and the vaccine. وأذر one mucoregulator هو الإدروستين هسه راح نشوفه إن شاء الله. والفيروس other even the vitamin D supplementation may be added to prevent further exacerbation. In the follow-up pharmacological treatment, this the last paragraph where the patient has more than 300 eosinophil count with a chronic bronchitis can be, according to the last guideline, may indicate dupilumab. Also in the treatment. This is the new drug and in the guidelines. This is the new drug, amphitrine, nebulizer, dual action, BDE3 and BDE4 combination. It's very, very new drugs and put in the guidelines. It is action to improve the bronchodilation, anti-inflammatory effect, and the mucociliary clearance. This is 2 studies about 77 and 78 patients with a COPD exacerbation are unreported. These studies in Western community, and I think in our community it is more patients with a COPD unreported. COPD exacerbation احنا نقول عليها بالعربي مثل الدوامة من worsening symptom صارت COPD exacerbation, decreased lung function, قلل physical activity, قلل mental health, quality of the life, further exacerbation, and end with the death and mortality. Exacerbation irreversibly reduce lung function, especially in mild disease. إذا نباو على ذاك الدايجرام الديكلاين مال ال FEV1 بالمايلد صار أكثر من السيفير, very severe. ف one exacerbation very declined بال FEV1 even with moderate exacerbation, especially in mild COPD. About only 50% of patients were alive within 3 to 6 years after first severe exacerbation. يعني حوالي 50% من الاكساسربيشن من البيشنت will die after 3 years. هاي مثل ما قلنا الجايد لاين الجديد ضافوا الاي to simplify the treatment strategies. MI and stroke risk increase in the first 10 days following moderate exacerbation, and also risk of cardiovascular event remain for up 1 year after exacerbation. Therefore, the prevention of exacerbation very, very important. COPD can be a modifiable risk factor for cardiovascular disease. And when we prevention exacerbation, this is very important modifiable risk factor. It can be preventive for cardiovascular severity and management. Coexisting of COPD and cardiovascular risk disease associated with dyspnea, worsening quality of the life, greater risk of hospitalization. Cardiovascular disease is common cause of death in the patient with moderate COPD. إذا باعون ذاك الدايجرام البيشنت with a moderate COPD and severe COPD. بالmoderate COPD cardiovascular risk cause of mortality, while in the severe COPD respiratory causes of death. بالمودريت سي او بي دي كارديوفاسكولار، بالسيفير سي او بي دي لا respiratory cause of death it is more. COPD associated with many comorbid disease like OSA, hypertension, hyperlipidemia, atrial fibrillation, but cardiovascular disease are among the most prevalent comorbidities and increased risk of death. Just one moderate exacerbation increased risk of COPD hospitalization by 27%. One moderate exacerbation. Also, the most important risk factor for further exacerbation, patient with a symptom. Patient with a symptomatic shortness of breath and cough, it is more risk for exacerbation. Even patient without a previous exacerbation, about 1 in 4 patients with 2 exacerbation do not have any recent exacerbation history. Any patient with smoking can be, and advanced can be a risk of exacerbation even without risk. Risk of exacerbation مثل ما قالوا الأساتذة increase with eosinophil count. إذا نشوف الدايجرام البيشنت with the bronchodilator treatment high risk of mortality, while patient on the ICS corticosteroid inhaler low risk of exacerbation. Therefore, identifying يعني patient at risk of exacerbation is key to optimizing management. History of COPD is very important. Increased dyspnea and productive cough, and patient with raised eosinophil count high risk. Why we call for needing early optimizing management of COPD to prevent exacerbation? This is summary. Just one exacerbation requiring oral corticosteroid and antibiotic increased risk of COPD exacerbation, and impact of COPD exacerbation beyond the goes beyond the lungs, significantly increase cardiovascular complication, premature death. Prior exacerbation, breathlessness, productive cough, or raised blood eosinophil, increased risk of exacerbation. Proactive management to prevent COPD exacerbation, reduce the risk of a premature death. So, therefore, we should be key prioritized for clinicians. In GOLD 2025 recommends initiating triple therapy with LAMA, LABA, and ICS for eosinophilic COPD patients during the first hospital admission. Thank you so much.
تفضل استاذنا محمد وهيب رئيس فرع الطب الباطني كلية طب بغداد، وغني عن التعريف طبعا، لتقديم ابديت ان سي او بي دي مانجمنت. محاضرة لشركة استرازينيكا.
شركة مو استرازينيكا، شركة
مو استرازينيكا، شركة ارمد. ارمد
هو يسوون بس هو اللي يقدم. العفو بس. السلام عليكم ورحمة الله. بس راح ناخذ النيو ريكومنديشن مال 2025 جولد كرايتيريا اللي هي 10 recommendation. The first one هي update information recording the use of spirometric critiform for airflow obstruction. أخذوا اللو ليفل versus المورتاليتي ريشيو versus الريشيو كانت less than 0.7 اعتمدوها. شافوا الفورس spirometry is still mandatory to establish the diagnosis of COPD. The gold is still favor using fixed ratio post bronchodilator less than 0.7, which is that lower limit of normal versus the fixed ratio and the mortality the same, which is again إذا كانت low limit lower limit of normal versus the ratio, which is the most important of the mortality rate, the same. Second recommendation هي diagnosis of COPD يعتمد على السيمتوم على الريسك فاكتور والسبيرومتري it is mandatory. The second this is the same كلته التريتمنت مالته. The second recommendation يقول لك pre and post bronchodilator spirometry value to consider COPD diagnosis. First, the gold recommended using post bronchodilator value more reproducible and identify the volume of response to bronchodilator in whom where the obstruction was revealed only after a bronchodilator induce increasing in forced vital capacity. Now we know the bronchodilator value are reproducible too, and post bronchodilator response has a little value, so it is depend on the pulmonary function test. Third recommendation here, reference value of lung function in spirometry interpretation of the severity impairment نقدر نعتمد عليه. عادة لذلك هسه قاموا يدخلون هي الناتشرال ريسز ايكويشن، قامت تعتمد ما كان يعتمد على ذاك، بدأوا يدخلون الناتشرال ريسز ايكويشن خلوها الاشياء اساسيه عم تقدر تحسب السبيرومتريك مال المريض. الريكومنديشن الرابع هو a new section of cardiovascular disease risk in COPD has been added to the Golden 25 document. All stable COPD patients must be screened for cardiovascular disease, which is the most important thing. This is مثل ما قال أستاذ أرشد, there is a close relationship between cardiovascular disease and COPD. الريكومنديشن الخامس هو the COPD patient discharged from hospitalization after acute exacerbating COPD must be educated, receive treatment optimization, and including in management of comorbidity, especially cardiovascular, which is the most important. The same ما طرح أسامة قبلنا. الريكومنديشن السادس وهو الابديت section on CT, الابديتد section on CT, chest CT, emphysema, lung, nodule, airway, and COPD comorbidity detected by CT scan. It is a must to be done. This is الكمبيوتر tomography. أما راح نشوف emphysema أو نشوف lung nodule أو نشوف airway أو نشوف COPD related morbidity. Our recommendation السابع, which is also most important, here a new section on climate changes and COPD has been added. بدأت هسه التشينج في الكلايمت بكل دول العالم, الهوت of the earth is increasing, دخلوها. So the risk of hospitalization شافوا increase with everyone's increase بالclimate temperature about 23.2 in summer's month. The recommendation is 8, the section of follow-up pharmacological treatment has been updated, which is include مثل ما هسه قلنا الدول ثيرابي ولا triple therapy, which will be used. وصلنا للتريبل ثيرابي, which is هو هذا اللي الاسرافينين دول ثيرابي اللي قلنا به 3 action to be effective. Recommendation التاسع, recommendation on the management of COPD patient currently on ICS LABA has been included. The gold recommendation has a triple therapy. Gold recommended the triple therapy if there is any indication for ICS use in the gold. High risk of exacerbation, high level of blood eosinophilia, and concomitant asthma, overusing of dual therapy, which is that paragraph. A recommendation العاشر, which is also recommended about pulmonary hypertension. Pulmonary hypertension diagnosis, the classification, and the management recommendation in patients with COPD section has been added. Normal recommendation hypertension, which is defined as the mean pulmonary arterial pressure more than 20. أكو شركة أرمل قدمت new drug, which is a combination of يسمونه الأجيوليكو بلاس, which is a combination of 2 drugs. هي for long acting LAMA, long acting. It is a combination of 2 drugs على شكل inhalation powder, hard capsule, الانديكاتريول والجلايكوبيرينيوم, which is هذا long acting anticholinergic و long acting antimuscarinic LAMA and LABA, which is usual. هذا يمشي نوع المقترح اللي طرح لنا دكتور رشاد انه الكورتيكوستيرويد is a criminal in future to be used as a maintenance. هذا المنت تعرف كليتها هي الاكشن مالتها, الميكانيزم اوف اكشن. المين main side effect of this combination of long-acting LAMA and LABA, after more than 27-week placebo and active control this, تقريبا ما لقوا في شيء side effect أكثر ما هو بس smooth muscle relaxant. الافيكاسي also جربوه بالافيكاسي in reducing COPD exacerbation. That is use as a rescue medication. نقولنا دائما نعطي على ذلك maintenance therapy هو هذا combination of both. And thank you very much.
Thank you very much, Ustad Muhammad. Next, our speaker, Dr. مصطفى نعمة، أستاذ مساعد في كلية طب بغداد، consultant غني عن التعريف. He is one of the eminent pulmonologists in our field. The subject of Singulair, the use of Singulair in asthmatic patients.
شكرا. السلام عليكم. شكرا جزيلا وشكرا لشركة الشركة الداعمة MSD اللي كلفتني بإلقاء هاي المحاضرة. The asthma, as you know, is a heterogeneous disease usually characterized by chronic airway inflammation, and the inflammation is the site of drug action actually, including montelukast. It is divided by history of respiratory symptoms, wheezing, shortness of breath, tightness, together with variable airway limitation, حتى نفرقها عن COPD. What are the updates in GINA guideline? Regarding the diagnosis, still there is an overdiagnosis and underdiagnosis of asthma nowadays all over the world. And respiratory symptoms are often, and this need high index of suspicion in cases of diagnosis of asthma, and therefore there is many potential diagnoses. مثل ما شفنا قبل شوي بالمحاضرة كان أكو upper airway obstruction, central airway obstruction, diagnosed as a foreign body, diagnosed as asthma, etc. We need a high index of suspicion, and you need to exclude other diagnoses. Globally, most clinicians do not have timely access to quality spirometry. الآن هواية من الأطباء بكل العالم ما عندهم السبيروميتر حتى يشخصون صحيح الأزمة، فهي أيضا نقطة مهمة حتى كل الأطباء يكون عندهم سبيروميتر at their office. peak expiratory flow إذا ما كان عندنا سبيروميتر لا أقل من أنه بالمناطق اللي ما يقدرون يجيبون سبيروميتر يستخدمون بيك فلوميتر. هذا لا أقل أنه يساعدنا بالتشخيص وبالريفرسابيلتي وبالفولو أب. Asthma is often inappropriately treated also all over the world as current acute diseases with no treatment in between. So there is a burden on the family, on the health sector. There is a risk of mortality, and there is a side effect of steroid, corticosteroid, with even 4 to 5 times lifetime courses. يعني حتى لو استخدمت 4-5 مرات الكورتيكوستيرويد systemic يعني خلال الأسمة خلال العمر المريض اللي عنده أسمة, this means a risk for the patient. فنحاول قدر الامكان نقلل من استخدام الاورال كورتيكوستيرويد، واذا استخدمناه فمعناها احنا ما لاكفين القضيه وين. Asthma morbidity and mortality is largely preventable. Asthma treatment is مو يعني بالعربي يعني مو شخص وروح اخذ علاجك وروح، لا، يحتاج ل الدائره من اللي هي review, assess and adjust. دائما نسأل المريض على السيمتومز من يجي سايد افكت اوف دراجز، نسوي له لونج فانكشن كل ربما 3 اشهر ربما اكثر او اقل حسب تقديرك انت. عندك كوموربيديتيز، لو ما عندك كوموربيديتيز صاير مثلا صار عنده هايبرتنشن دايابيتس حتى التريتمنت مالتنا نفحصها زين نشوف اذا عنده اورال مونيلياسيس، نفحص طريقه الاستخدام مال انهيلر كل ما يجي انهيلر تكنيكس يعني تريتمنت of modifiable risk factor إذا كان allergen, occupation عنده مشكلة بها، home exposure. وهاي طبعا هواي عندنا حالات ما تعرف ليش انه المريض ما يصير زين، بالرغم ان انت كل الستاندرد مطيه له، بس يبقى المريض يعاني، عنده some sort of dyspnea. واحدة من الكيسات اللي اتذكر يعني حكوا لي عليها الجماعه انه ايضا ما تصير زين البيشنت، ما تصير زين من الاسمى. بعدين راحوا الجماعه للبيت انه حتى يشوفون، طبعا مو عندنا هاي اوتسايد، ولقوا انه اكو فد bird drops at the window of the patient near the hair bed. فقريب من كان اكو هذا الالرجينز اللي دائما تصير بي exacerbation، تاخذ التريتمنت بس مجد تنام اكو الرجين بصفها تشتمه طول فتره الليل، فهم يحتاج لها نسال المريض على البيرد انيمالز. وهسه ما شاء الله معظم البيوت عندهم لو بيرد لو كات، وبعدين تطورت القضيه صارت دوغ سمينا موجود. فيعني لازم تدير بالنا احنا نسال المريض دائما حول هذه الاشياء regarding the adjustment and assessment. Recently also there is 2 tracks of treatment of asthma. Track 1 اللي هو preferred one, track 2. track 1 كانت الستبس مثل ما تذكرون حضراتكم، ستيب 1 بعدين ستيب 2 ستيب 3، هسه بعدين اندمجت ستيب 1 and 2 as needed low dose ICS formoterol، بعدين تصعد ستيب 3 لو دوز، بعدين ميديوم دوز، بعدين ربما هاي دوز، تضيف هنا بعد اللامه، وممكن نسوي له فينوتايبس وكونسيدر هاي دوز اوف انهيلد كورتيكوستيرويد، بعدين اميونوثيرابي او بيولوجيكال ثيرابي. هنا اللي شفنا انه فينوتايبنج بستيب 5 تسويها، بس بالحقيقه هسه ريسنتلي اكو ستديز تقول انه الفينوتايب سويها as early as possible. يعني مو بس المريض لما يجيك uncontrolled asthma تسوي له فينوتايب ايوسينوفيل واي جي اي واذرز، لا يعني الستديز اعتقد هاي بالجايد لاين الجديده مال السنوات القادمه راح يخلون الفينوتايب early as possible. كذلك السي تي سكان اوف ذا تشيست هم ستديز تقول، يعني ما حافظ الستديز بس يعني بالمؤتمرات دي يحشون بها انه السي تي سكان sometimes needed early in patient presented with moderate to severe asthma، لانه قد يكون ABA allergic bronchopulmonary aspergillosis developed and you cannot detect by simple test and examination. التراك 2 بالمناطق الفقيره اللي ما يقدرون يعني ياخذون ICS فورموترول يقدروا يستخدمون التيك ICS ونيفر سابا. يعني سابا هنا موجود بالستيب 1، وبالرغم من انه الاستاذ قبل شويه رشاد قال انه سابا maybe not used in the future plan of GINA guideline، بس المهم هذا مال 24 موجود and you need to use ICS whenever سابا is taken. ستيب 3 بعدين الصعد تستخدم لو دوز ICS، بعدين فورموترول ICS، وبعدين نفس الستبس تقريبا الباقيه. هنا وين دور المونتلوكاست؟ مونتلوكاست كل الفقرات تقدر تضيفها من ستيب 1 الى ستيب 5. نشوف هنا اللي جواها خط، تقدر تعوض المونتلوكاست عن انهيلد كورتيكوستيرويد كانتي انفلاماتوري. اوكي، بالستيب 1 ستيب 2 ستيب 3 ستيب 4. يعني there is a rule و there is many studies about this. فمثلا واحد ما يقدر يشتري الفورموترول ICS، نقدر نضيف له المونتلوكاست انستيد اوف ستيرويد. فهذه تكبير للفقره السابقه. جينا assessment of symptom control. symptom control نسال المريض انه عندك يوميه العلامات او مرتين بالاسبوع، ايش كم مره تقعد بالليل بهذا الاسبوع، تحتاج تاخذ ريليفر يعني اما تستخدم سابا ICS او ICS لابا تاخذهن، اكتيفيتي شلون فعالياتك وهذه خلال فتره الاسبوع، حتى نعرف انه ويل كنترول لو بارتي كنترول لو نوت كنترولد according to the number of these assessment. The need to change asthma treatment management and real life issues. Many asthmatic patients remain uncontrolled. طبعا هذا الكلام كل العالم. 94% did not meet all GINA criteria for asthma control according to a study. 51% not meet the criteria for asthma control despite the use of ICS or ICS LABA according to an INSPIRE study. والهيلث كير ريسورسز دائما تحتاج تزيدها لما يكون اكو عندك allergic rhinitis associated with asthma، فالهيلث كير والريسورسز يوتيلايزيشن راح تزداد، quality of life راح تقل اذا كان associated allergic rhinitis. المونتلوكاست how singular could be used in some studies when there is allergic rhinitis associated with asthma, and it is beneficial in such conditions. Dual pathway of anti-inflammatory عندنا أو inflammation بالاسم. الباثوي اللي هو سيستينيل لوكوترينز، والباثوي الثاني الستيرويد ميدياتورز. يعني يختلفون الستيرويد عن لذلك احنا مرات نستخدم الستيرويد عفوا سنجولير او مثلا instead of inhaled corticosteroid. اذا two pathways. هذه صورة ثانية عن اللوكوترينز دي 4 واثرها على الايوسينوفيل. عند ايوسينوفيل ماتوريشن، عند ديفرنشيشن. شوف نعمل الايوسينوفيل كل سيستينيل لوكوترينز، survival of eosinophil secretions, differentiations, chemotaxis، كلها الريسبتورز اوف لوكوترين موجودة بها. عندنا 3 ستاديز. المونيكا ستادي رقم 1 مونتلوكاستين كرونيك اسما كنترول ستادي. فلما نضيف المونتلوكاستين inadequate control asthma patient in 6 months open label study، النتيجة كانت أنه treatment with montelukast in addition to inhaled corticosteroid. هنا عندنا مثلا الجروبس اللي هي البيس لاين و 3 months و 6 months. هنا البيشنتس in early asthma control test. فنشوف الكنترول بالأشهر الأولى في بداية الأمر 13%، لما صار 3 أشهر صار 41%، ولما صار 6 أشهر of adding montelukast in addition to inhaled corticosteroid صار 47%، بينما ال completely controlled كان قليل. فإذا كل ما فاتت الأشهر فما نقدر نقيم adding add-on therapy خلال أول شهر أو شهرين أو 3 أشهر. فلازم نقول للمريض يعني التقييم النهائي مالتك لابد أن يكون ورا 3 أشهر إلى 6 أشهر حتى نعرف أنه نغير الدواء step up step down، يعني ما يصير من أول شهر نغير. أيضا عندنا الامبروفمنت in asthma control test score with add-on montelukast in subgroups. هنا عندنا ICS group alone، ICS lab group، وهنا نفس الشيء البيز لاين والكنترول مالتنا. كل ما فات الوقت كل ما صار ICS subgroup in addition to، هنا الملاحظة addition of montelukast in ICS group صار fully controlled up mostly controlled 54%، بينما الكومبينيشن مع العلم هذا كومبينيشن سب جروبس وهم نضاف لمونتلوكاست 45. وكأنه هنا نشوف انه adding of montelukast in addition to inhaled corticosteroid without LABA is more effective in this study. Also improvement in many asthma quality of life questionnaire لما نضاف المونتلوكاست. Improvement in lung function with adding of montelukast compared to ICS and LABA. And summary of this study is that asthma control in 3, 6, and 12 months significantly improved, quality of life improved, and lung function improved after addition of montelukast in this patient. الستادي الثانية الكومباكت ستادي clinical observation of montelukast as partner agent for complementary therapy compact study. هذا بسنة 2003. أيضا addition of montelukast to budesonide 400 وصار التقسيم مال انه budesonide 400 twice daily singular placebo once daily أو to compared with singular montelukast once daily budesonide 400 budesonide 800. هذا الكومباريزن. So the improvement on the baseline continuously improved. الأبيض هو الاديشن of montelukast، الأحمر هو without montelukast is seemingly more effective in controlling symptoms. Also onset of action إذا أضفت المونتلوكاست onset of action راح يصير more rapid in cases of montelukast compared to without montelukast. More rapid onset of action. Nocturnal awakening with asthma baseline also improved with montelukast group. So in summary, treatment with montelukast and budesonide and was at least as effective as doubling the budesonide dose. يعني مكان ما تسوي doubling للبودوسينايد اضيف المونتلوكاست and faster onset of action. And it is improving the awaking or decreasing the awaking at night. الستادي الثاني اللي هي impact study اللي هي investigation of montelukast as a partner agent for complementary therapy. هنا الامباكت ستدي تقريبا تشبه المعلومات مال الكومباكت ستدي. فعندنا مجموعه من 1490 بيشنت اللي هم مونتلوكاست فلوتيكازون او سالمترول فلوتيكازون الون، والكومبليت ستدي منهم هالقد. وشوف هذول اللي discontinued هسه راح بعدين نجي على ال percent with no asthma exacerbation was similar between both group. يعني إذا أضفت مونتلوكاست to the fluticasone أو salmeterol fluticasone تقريبا نفس الشيء regarding the no asthma symptoms. ف combined inhaler أو one inhaler زائد المونتلوكاست is the same. Improvement also in asthma specific quality of life همين تقريبا compared altogether between two groups. And reduction in nocturnal awaking also are the same. But it is in cases of montelukast, it will more decrease the eosinophil compared to the combined inhaled therapy ICS and LABA. فلما نضيف مونتلوكاست راح نتوقع الايوسينوفيل تقل اكثر مما لو كان only inhaler treatment. مثل ما قبل شويه شفنا الايوسينوفيل pathways in montelukast. So a patient receiving montelukast plus with the fluticasone had fewer drug-related and serious adverse events. يعني راح مثلا تكيكارديا اللي عند المريض والاشياء اللي تصير وهي long acting beta agonist راح تصير اقل. اكو بعض الليترشر تجي عليها على السريع اللي هي montelukast use decrease cardiovascular event in asthmatic patient. وهذه هم معلومه بالنسبه لي جديده الحقيقه. بال 2021 طلع هاي الاستدي باي مالفينا انه why there is a decrease in cardiovascular event in asthmatic because cysteine leukotrienes are pro-inflammatory mediator. It is linked to asthma as well as cardiovascular diseases اللي هذا cysteine leukotrien. بما انه المونتلوكاست يشتغل على cysteine leukotrien ويسوي لها blockage, so there is improvement in asthma and decreasing the rate of cardiovascular side effect or cardiovascular events. So this study aimed to know the side effect or the events, vascular event, and the analysis showed the montelukast exposure reduced the ischemic by 76 to 78%. يعني كلش عالي الرقم. إذا خلال هاي الاستدي انه decrease the cardiovascular events. تمام. الاستدي الثانية على السريع دقيقة واحدة فقط. ايضا مونتلوكاست alone بدوسنات فورماتور alone and covariant asthma. It is also comparable يعني between both. الستدي الأخرى اللي هو therapy in elderly patient, in severe asthma in elderly patient, it is preferable to use montelukast in elderly patient than to increase the dose of LABA. Antidepressant medication dispersed among montelukast initiation. يعني تعرفون montelukast بي psychological side effect. واكو study قالت الانتيدبرسنت ربما تزداد يعني هذول تستخدمها اكثر المرضى اللي يستخدمون مونتلوكاست. فنحتاج انه احنا be aware about this. مثل ما تعرفون سنجولير موجود بمختلف الدوزات. granules for children, chewable tablet 4 milligram and 5 milligram and adult dose 10 milligram. Never use oral singular to treat acute asthma. Should not substitute abruptly inhaled steroid. يعني إذا تريد تبدل مكان inhaled steroid ما يصير رأسا. So graduation. In rare cases there is Church-Rau syndrome and there is no effect about aspirin sensitive asthma. يعني كل هاي إيجابيات واستخدام المونتلوكاست. Pregnancy not contraindicated إذا كانت تستخدمه سابقا. شكرا جزيلا.
The last speaker is الأستاذ الدكتور كاميران قرداغي, intensivist and FRCB, consultant immunologist and consultant internist, board respiratory medicine Norway, board in respiratory medicine and allergy in Sweden, program director of respiratory medicine Kurdistan, high council of medical specialties. يتفضل قام محاضرته حول asthma and special population, sponsored by Diva Company.
Thank you very much. So, thanks Diva for support this talk. This is a new terminology for myself, and I didn't find in Google, PubMed. So, I would like to tell you, please take housewife as a concept, not just a trigger for one disease. So, in the last 10 years, we have discussed a lot of subjects. It is called indoor pollution. So indoor pollution, the first person, wives, and the second children. And men inside the house really is a risk factor for indoor pollution. So he is a risk factor for indoor pollution. This terminology, housewife, is an indoor asthma, home-associated asthma. I try to find the same terminology. This is from myself. And I would like to discuss with the GINA group as a committee, and I will discuss with them about this subject and how. Because in Norway, we have something what's called sarcoidosis syndrome. Norway is the only country in the world, about 17% they have sarcoidosis. But in Baghdad, we have maybe less than 1%. So, it is increasingly clear that asthma is a complex disease made up a number of disease variants with different underlying pathophysiology, limited knowledge of the mechanism of these diseases. You know, if you look to the category, they refuse these categories, allergic, non-allergic. So we have more biological pathway in endotypes. But what I would just like to say, we have for me, this is a new phenotype inside asthma. We have about 17 phenotypes inside asthma, but for me, it's the last, according to my knowledge and my working with this group of people. We are described a hypothesis whereby the asthma, this is it is about 2011, before biological. But the first biology, omalizumab, so I was one of the first study in Norway in omalizumab for 11 patients, and after that, nuclear drug. So at that time, which we have called asthma endotype in the small parenthesis. So endotype, for about 13 years ago, we discussed what is called endotype and something asthma endotype, and criteria for defining asthma endotypes based on their phenotype and putative pathophysiology are suggested. For housewife syndrome, for housewife asthma, we have about five risk factors from the dust, from the tape, from the cleaning material, from the humidified cooking, from the smoking, from all mild. So they have 5 non-allergic risk factor trigger. So how we can define these group of people in our region? This is not, because I told my candidate, don't write down in history taking HW. What's the meaning of HW? It's housewife. What's the meaning of housewife? You must describe them, and is this an obese patient or not? Now this group, this phenotype, they are obese patient. They eat in every food, the children too. The rest of the children they will eat. And this is one of the risk factors. They have, it is called housewife syndrome because they have USAI. They have obesity, sleep apnea, and they have asthma associated weight and these factors. And this mechanism pass endotype and variable clinical presentation for phenotype, and this is for the long time. And asthma endotype may be broadly regarded as T2 higher or T2 lower. Several biological agents have been approached for T2 high asthma. This is one of my point. On this group, is it really in candidate for biological therapy according to the risk factor and other things? I heard about roflumilast, dupilumab, PD3, phosphodiesterase 3 for COPD. It is wrong. You must write COPD dash chronic bronchitis. Emphysema, we have not indicated for roflumilast, dupilumab, phosphodiesterase 3 and 4 for emphysema. We know the pathophysiology of emphysema. It's a destruction of the tissue. How you can give biological therapy for this? And sometimes I hear you forgot the term of asthma COPD overlap syndrome. Really, these biological roflumilast, it's indication for this group of people. Asthma COPD overlap syndrome, in parentheses, it means chronic bronchitis. So this COPD from the guideline, that's the chapter of the GINA guideline, it is not correct. I have discussed this many, many times internationally. It is not a correct address. And according to this study, asthma is a chronic inflammatory disease. Multiple pathophysiological event, pathophysiological driven culture of disease, driven clusters of disease exist. The main phenotype that have been identified include early onset asthma, early onset allergic moderate to severe, and late onset non-allergic eosinophilic asthma, and late onset non-allergic non-eosinophilic asthma. And this housewife's asthma, I wrote my name here because this is I'm sorry I have brought today. Housewife asthma most likely belong to the number 4. Late onset, non-allergic, non-eosinophilic asthma. And from the OH to 15 years of old, it's a boys more than asthma more than female. And after 18 years, so the prevalence of asthma more in women than men. So may I can continue 2-3 minutes or? This is my message. This is because I have more slides about endotype and clinical endotype, clinical, you see, about the clinical phenotype, pathological, and response to treatment and prognosis factor in this group of patients. And you see, you have familiar with this allergic asthma, intrinsic asthma, neurotrophic asthma, and or aspirin, and some other, we can say phenotype and endotype together corresponding to each other. COPD is a heterogenic disease. Continuous exposure, indoors, associated asthma, airflow limitation. Still, we have a problem how we can treat this group of patients. We have some group of these patients, are calling them wheezy patient. Wheezy chest. They have wheezy chest because we are not dealing with the risk factors. And they have, if you look to these patients, if you have a good study about this group of patients, about 85% of them, they are overweight. They are overweight. So it is very important. And this phenotype, asthma COPD overlap syndrome, it is not the endotype, it's a phenotype. Because chronic bronchitis, by definition, is a chronic cough and sputum. Emphysema is a IHRCT diagnostic. It's an anatomical finding. And asthma is a functional because of the spirometry. So, early stage of ACOS may appear in housewife's ACOS, asthma COPD overlap syndrome, and asthma phenotype, susceptibility to obesity, and we have exaggerated response to smoking and air pollution. Here is the indoors pollution and overweight at home. And this uncontrolled severe asthma is associated with multiple type 2 inflammatory, chronic rhinosinusitis, rhinosinusitis, and gastroesophageal obstructive, and these continue may share a common pathophysiological mean with asthma, influenced asthma control phenotype and present to treatment be more prevalent in asthmatic patients, but without obvious influence of the disease and major comorbidity with these two group of patients. Uncontrolled severe asthma, non-eosinophilic allergic asthma, housewives asthma must be put in our consideration. Thank you very much.
Thank you. Thank you very much. I ask the speaker to come here in the stage, our eminent speaker, and we have 5 minutes for just for question for everyone.
Dr. Arshad.
Okay.
Regarding the relation between ischemic heart disease and chronic obstructive lung disease. There is a study in India, 40,000 people. The incidence of ischemic heart disease more than 5% in patients with COPD. But on the opposite side, thousands of people with chronic obstructive lung disease have been unnecessarily underwent cardiac catheterization for similarity of symptoms, and I am having an ongoing study, collected more than 40 cases till now of people with COPD with totally normal coronary artery disease. The interventional cardiologists are snipering any case of chest complaint.
Heart disease. That is why we have very vigilant in the diagnosis of ischemic heart disease in patients with COPD, because as you said, there's many similarity of symptoms between both conditions. As you see in these slides, for example, the treadmill test is not used in the diagnosis of ischemic heart disease. We have to rely on the dobutamine stress test, which is really done in my country. Really, we depend on the stress test. That is why maybe there is overdiagnosis of ischemic heart disease in case of COPD. It is not shameful to, if you suspect patients with suspecting to have ischemic heart disease in COPD, to go to coronary angiogram, because it is life-saving. If you suspect it and you do coronary angiogram, it is normal. It is not shameful. It's good for the patient and for the doctor also.
السلام عليكم. الجميع إن شاء الله مساكم الله بالخير جميعا. Dr. Rashid, سؤالي لحضرتك. As we know, there is an increasing risk of cardiovascular disease post-acute exacerbation. Whatever the exacerbation, mild or moderate or severe, up to 300 times in the first month and up to 100 times in the first year post-exacerbation. What can we do to minimize this risk? Should we start statin, anticoagulant, antiplatelet, or should we refer to the cardiologist as a part of MDT?
Well, they are found to be safe. Statin, ACE inhibitor, maybe some information or data I'm not presented in my slides, but they have found that aspirin, statin, ACE inhibitor, they're all safe, except for the non-selective beta blocker. They're all safe. They protect your patients regarding the increasing the risk of ischemic heart disease. They protect your patients. So some information not mentioned in my slide, but they have found they are very beneficial in decreasing the risk, including statin, including aspirin also in patients without erective airway disease, without asthma. But in COPD, you can use it. Even statin, even ACE inhibitor, they all decrease the risk except for the non-selective beta blocker.
Should we use it for just 1 year to minimize the risk or for lifelong?
No, once you have a risk, you have a risk. Once you have a 10-year risk high, you have started for life. For life, should be.
Thank you.
No more questions. Thank you for all. We have the audience, and I think this is the end of our session. And also, if we have any question, we can join any one of these speakers to tell him during this. Thank you very much for joining us.
شكرا جزيلا أستاذ عبد الحميد. أخوان الغداء جاهز، مطعم اسمه أم شريف بجلستين، جلسة على النهار وكو جلسة داخلي اللي يحب، وكو مصلى هنا اللي يحب يصلي. عندنا ساعة واحدة فقط، كانت ساعة ونص بس أخذناها تغدينا علم. يلا لكم ساعة 3 ناس اخوان.